So good morning, everyone. It's a real pleasure to be here with all of you and to see so many people. I'm Ellen Starbird. I'm the director of the Office of Population and Reproductive Health. Is that better? Okay. And I want to welcome all of you to this last technical consultation of the LARC PM Community of Practice as it transitions to the first technical consultation of the Contraceptive Method Choice Community of Practice. So to all the members of the LARC PM COP and all the members of the Contraceptive Method Choice COP, welcome. I'm happy to see this transition taking place, as contraceptive method choice is an indispensable component of making voluntarism and informed choice a reality. In fact, we can think of true method choice as the culmination of many of our other efforts: strengthening the policy environment, supply chain effectiveness, contraceptive research and introduction, provider training, social and behavior change, etc. And broad method choice, accompanied by individual agency and comprehensible information, is also likely to improve contraceptive continuation and user satisfaction. If you can get the method you want, understand how it works, switch when you want to, you're more likely to be satisfied. We at USAID, and all of you here I know, have a long-standing commitment to method choice. We've worked together to support the development of new contraceptives and technologies, DHS measurement of contraceptive use, and research policies and high-impact practices. And these elements taken together have helped expand access to a range of contraceptive methods, information, counseling, and services for women, men, couples, and youth in a multitude of settings and geographies. So with 2020 right around the corner and looking forward to the next decade through 2030, today's an important moment for us to reflect on our contributions to method choice and on what more we can do to make accessible and affordable method choice a reality for millions more individuals and couples. And even as we consider the demographic reality of the large numbers of youth entering their reproductive years and the types of methods they want to use, we must also consider the contraceptive needs of current users to space their pregnancies or to reach desired family size. We remain committed to being a leader in advancing contraceptive method choice, including methods at both ends of the spectrum: fertility awareness methods and long-acting and reversible contraceptives and permanent methods, as well as all the methods in between. We're also committed to supporting the development, introduction, and scale-up of a wide range of contraceptive methods to meet the varied needs of new and current family planning clients across all stages of their life course. Today's meeting to transition from the LARC PM COP to the Method Choice COP has an exciting agenda that I hope you've begun to look at, beginning with examining what the data tell us, then on to country experiences to operationalize contraceptive method choice, and a debate on method choice, before engaging all of you in co-creating this method choice community of practice together. So to get us started, I'd like to turn to Trish McDonald, under whose guidance the LARC PM Community of Practice came into being, and which, with the sustained engagement of many of you, helped advance progress in increasing access to these methods. The transition in focus from LARCs and PMs to method choice does not leave that work behind. Rather, it reframes it in a broader context that I believe will help us make real method choice a reality for more people in more places in the coming years. So a little bit about Trish, who I think you probably all know fairly well, but nonetheless. She joined the office's service delivery improvement nearly 15 years ago to manage the Acquire and Respond projects, both of which had a focus on LARCs and PMs. Currently, Trish manages the Evidence to Action project and the family planning component of the Maternal and Child Survival Program. And incidentally, both these projects are also co-hosting today's meeting. So thank you to Trish for her long-standing commitment to LARCs, PMs, and method choice, and to E2A and MCSP for hosting. So I'd like to welcome Trish to come on up here and get us going.
And we can start on her and then go to her slides. Sorry about that. Thank you, Ellen, and welcome, everyone. It's so great to see everyone. I hope you can all see the screen. Oh, okay. And as the title of today's meeting is about looking backward and then looking forward as well. So we've had quite a long history with the LARC PM community of practice. It started 10 years ago under the Respond Project, and it's gone through several names. Started with LAPMs, partly because these were really provider-driven methods. We had to have trained clinical providers for them. But then we realized that long-acting methods are not the same as permanent methods, and so the hyphen and the slash between them to try and, help everybody understand that not all long-acting methods are permanent methods. And then the new terminology of long-acting reversible contraceptives, or LARCs, came about, and so we've become the LARC PM community of practice. So we've continued to evolve a little bit over the years. We've had a number of different projects serving as secretariats. Respond in its project life, the SIFPO PSI project, MCSP, which is ending this year, and E2A, which is taking over for its final year, and we'll see where we go from there. So over the years, some of the activities that the LARC PM community of practice has undertaken has been the formation of different technical working groups to really take on and address very specific kinds of scopes of work. Whether it's a research agenda, toolkits, updating or development, curricula updates, looking at the conversion factor for CYP, and then having very specific working groups around each of the different methods to address those needs of those methods. The community of practice has also hosted a number of technical consultations, such as this one, as well as webinars covering a range of topics from data to counseling, youth, private sector, social franchising, integrated services, etc., as well as the method-specific topics and moving from introduction to scale up. So now as we start looking at the issue of method choice and method mix, one of the things that we often hear, I often hear, you may as well, is a little bit about, are they the same? The terminology is often used interchangeably, and what is it really? So what are we talking about? Well, we have a lot of contraceptive methods at in our programs, ranging on the top line there from the LARCs, the implants and IUDs, and the permanent methods, to the full range of short-acting and hormonal methods, the fertility awareness methods, including LAM, barrier methods, etc. So what is that method mix? Is it method choice? What's the same? What's different? So we've been working on a bit of a definition. Oh dear, one of these kinds of slides. Okay. So looking up the definitions of method mix, we found two different definitions. One, which kind of categorizes method mix as a set of inputs. In other words, the menu of contraceptives available in a country, which is the definition used by WHO. On the other side, it's really looking at the outputs or the outcomes, the percent distribution of contraceptive users in a country as defined by measure evaluation. So the method mix is what percent of users are using XYZ method. So we had to look at now what is method choice and how is it different from method mix as an input or an output. And we really had to look at the process. And so we've come up with a definition, which I'm sure the community may decide to reflect upon, revise as needed, whatever, but this is just to get us started. We've used it in our family planning training courses and things. So we define method choice as client-centered information, counseling, and services that enable women, youth, men, and couples to decide and freely choose a contraceptive method that best meets their reproductive desires and lifestyle while balancing other considerations that are important to method adoption, use, and change. It says a lot, client-centered. I mean, this is how do we interact with our clients? How do we make sure that we're speaking with them respectfully, providing, correct and adequate information to them, helping them decide what works best for them. And it's not just the medical eligibility criteria, but what do they want in terms of their lifestyle, which may not even be related to their fertility preferences. So all of these factors together can come together as part of that whole method choice perspective. So then we looked at all the other things that influence the ability to have true method choice. And under the inputs, you see we've got supply chain, SBC, providers, policy, finances, etc. Those are also inputs that enable us to program for comprehensive method choice. On the other side, as the outputs, we have things like medical records and registers, health information systems, DHIS, and surveys that provide us with the kinds of data to really understand how our programs are functioning. So getting from inputs to outputs is a kind of a large process that encompasses a lot of things. So now, oh, there's still more. Okay. So now looking forward, and looking at sort of many and one together. And so the many includes many of the contraceptive methods specific communities and working groups that are currently functioning. Not just the LARCs and PM community of practice, but there have been, and there are, groups that are specifically working on things like implants and DMPA sub-Q, which are volume guarantees, have been volume guarantees that have had their own groups and subgroups and task forces working under those. We have the next indent there is kind of a lot of the underutilized methods that may have their own kinds of special needs. Moving further along is method introduction, new methods, new technologies. So the LNGIUS, the Kaya diaphragm, the progestin vaginal ring, for example. There are more. We also have new method development, things that haven't even come onto the market yet but are in development, such as the microneedle patch, for example. And then we've also got, in terms of method specific, is also related to specific populations. And the updates to the medical eligibility criteria, for example, for postpartum and the use of progestin-only methods immediately after birth, as well as the updates on hormonal contraceptive use for prevention of HIV acquisition and other results that come out of the ECHO trial. So these are all parts of the different things that influence us as a larger community. Well, if you thought that's not enough, there's more. We also have communities of practice, working groups, and others that really look at how we implement and reach specific target groups for types of clients. So, postpartum women, post-abortion women, looking at how to integrate with HIV services, reaching youth, young first-time parents, and male engagement and gender dimensions that all influence this. So there's a whole group that work around specific population groups. And then there are other groups that work on, is that mine? No. Other groups that work on cross-cutting topics and areas, total market approach from public sector to private sectors, NGOs, FBOs, the gamut. Service communication, which is sort of an integration of SBC and service delivery. Task sharing, how do we reach more clients with different cadres of providers? Scale-up approaches, coordinated supply planning, which is essential to enabling us to have methods to provide choice, and research and data and high-impact practices that have emerged from some of that research and data that's come out. All of these that are contributing, and more. This is just some, so there's probably even more. So we are many, and we have a lot that's going on. And then there are the different organizations and movements that are happening to really catalyze and move forward from the global movements of FP 2020 and on to 2030, country governments and their health systems, local organizations, global and regional partners like WAHO and the Ouagadougou Partnership, for example, all the different bilateral, technical, multilateral donors, and then there are many other method-specific and operational working groups that are all kind of working together to advance method choice and contraceptive use. So as we look to the future now and where we're headed, just a few thoughts on the kinds of things that a method choice community of practice can do in providing a platform to advance shared learning, not only about the methods, but also how we take them from introduction to scale, how we innovate around service delivery approaches, understand user dynamics. It also offers a platform to strengthen collaboration, commitment, and support for client-centered programming and how we make our programs much more effective for enhancing method choice. It provides thought leadership on emerging issues, such things as, working in humanitarian assistance settings, which are becoming more and more frequent in many of the countries we work, and looking at new innovative ways of perhaps combining or repositioning different methods. So one example would be permanent methods with the FAM, fertility awareness methods, and LAM. Why? Well, because they're all non-hormonal, and there may be real appeal to packaging them that way. But it gives us an opportunity to be creative, to be innovative, to be thought leaders, and move the field forward. So with that, I'm going to just sort of turn it over to Jane Bertrand, who's going to open our first panel and really get us kicked off now for or were we going to have a Q&A? Sorry, was there going to? Panel. Oh, the panel, okay. But if there are questions, I think there's note cards on your tables if you have questions, and we can answer those at a later time. But please join me in welcoming Jane, who's the moderator for our very first panel.
And while Jane's getting set up here, just a reminder for those in the room that you have note cards on your tables to please write any questions and your name and organization. And those joining us online, please chat any questions in the chat box, and we'll be sure to get them up. And I'd go ahead and invite, just briefly while we're getting set up here, the rest of the data panel, if they would like to please come up as well. And then those who don't have seats yet, there's a lot at the back of the room if you want to take advantage of a lull and find a table.
Do we have all 4 panelists? We're missing Rebecca. Good morning. It's a real pleasure to be here, to see so many colleagues, some former students, that's always a big source of satisfaction, and to lead off on this panel entitled, What Can Data on Method Availability and Method Mix Tell Us About Method Choice? I'll save introductions until afterwards, and Trish did me the favor of going over what were on the first 2 or 3 of my own slides, so I'm going to move quite quickly through this, emphasizing that today's session really is on method choice, and we will hope that our different presentations here circle back to that theme. I'm going to start out with method mix, and several of us are going to be talking about method mix. Method mix is an objective measure. It is not good, bad. It is simply when you take the 100% of users in a country, what is the breakdown? What is the share of each method corresponding to the different available methods?
I should point out that FB 2020 and PMA 2020 look at method mix based on modern methods, the 100% of modern methods. This presentation will take a look at it based on modern and traditional methods. We're starting with a pop quiz today. Guess the country that has 68% female sterilization? India. I'd also like to reinforce this idea. There is no ideal method mix. We like to talk about countries should be moving toward a balanced method mix. Well, what does a balanced method mix mean? This is what a balanced method mix would look like. 12.5% for each of the major methods here. And obviously, this does not represent clients' desires. Many would question if vasectomy at 12.5% would be realistic or desirable. Some would question if traditional methods at 12.5 is really where a country wants to go. So it's useful to look at that as what balance looks like in the absolute sense. It is fun to look at what country has the most balanced method mix. And Sri Lanka is the winner as of the most recent survey. And you can see that this does look a lot more, it looks almost like the previous one. Vasectomy is at 0 in this. Female sterilization is at 22, and traditional is at 17. So we could talk about this, but it is interesting just to take a look at which country that would be. Let me show Sri Lanka a second way. We're finding that area graphs are very useful in helping us understand the progression or the evolution of method mix over time. So what you're looking along the bottom axis is the different surveys from the first one in 1975 to the most recent in 2016. And we're talking about the share. Let me contrast prevalence to share. The prevalence is the rate. It is the percentage of women using a specific method. The share adds to 100%. So we need to take those two, and this shows share. At any point in those surveys, of the 100% of users, what was the method mix? It's also a great example of a country that went from a very high share of traditional methods. In 60% of users were relying on traditional methods, down to what is now a much more balanced. The right-hand side in 2016 is showing the same thing that we saw on the previous pie chart. Also interesting to look at female sterilization, which peaked during the 80s, but then did level off to a somewhat lower level. We were asked not to forget about LAM and fertility awareness-based methods in this presentation. I don't know if I'll talk for my other colleague or other panelists, but I will talk for why in my presentation there is nothing or no data on LAM and fertility awareness-based methods. The first two columns show LAM. There are, in fact, 70% of the most recent DHS surveys in 83 low and middle income countries do have data on LAM, but they come to 1% of the population, less than 1% actually using LAM. In terms of fertility awareness-based methods, we do have fairly good data on rhythm, but in terms of cycle beads, it is not a consistent measure in the major surveys. In fact, 3/4 of the surveys do not have data on fertility awareness-based methods apart from rhythm, and where they do, it is much less than 1%. So I'd like to show some data from a paper that's currently under review at International Perspectives. The co-authors are John Ross, Tara Sullivan, Karen Hardy, who's with us here today, and Jim Shelton. I should also give a shout out to John Ross, who helped me in the preparation of a number of the slides we'll be showing today. The first of these several trends that let me just say several of you are familiar with the papers of Tara Sullivan and I did a paper on method skew, John Ross and Kieran and others did a paper on method mix as well. And recently we decided, well, let's get these two teams together and just write one paper. So this is the result from it. And there were several main trends that we pulled out of this. The first is that traditional method share, again, this is the percentage of the 100%, is decreasing, has declined over time. But what's surprising is that despite the efforts of everyone in this room to make modern methods available in so many countries worldwide, traditional method use still represents 17% of the share of overall use. You can see how this is differed by regions. There's been a big drop worldwide, and this is based on 113 countries available in the UN population database. Sub-Saharan Africa has seen the biggest drop in traditional methods, but over time, again, comparing the first survey, which in many cases was conducted back in the 70s, with the most recent survey, in all regions except North Africa and West Asia, we see this drop in traditional methods. I know that, Emily, you're going to show a slide that's very similar to this. As we talk about this, there's no single method that dominates. It's not like some method came in and swept the world, and now this is the method that is the leader in these different countries. It is true that the pill is the method that predominates in 22 countries, injectable in 20, traditional methods in 17, etc. But it certainly does give this idea that in different countries, different methods are either being made available or meeting the needs of that population. I think, to me, the single most interesting thing coming out of this study is that the leading method differs in the four main regions of geographical regions. In Asia, the leading method is the IUD. In Latin America, it is female sterilization. In the Mideast and North Africa, the pill and traditional methods tie for that leading method. And in Sub-Saharan Africa, it's the injectable. So overall, when you take this, take a global look at this, the pill is actually what continues to predominate. But interestingly, it barely makes it as the leading method when you look at it on a regional basis. Here's a slide that's not going to be news for many people in this audience. The share of vasectomy in programs has declined from low to lower. Again, we're comparing the first study, which may have been 3 decades or more ago, to the most recent. Nepal was the country that at one point had the highest share of vasectomy use. Way back when, it was 47% of all use. It has dropped now to just being slightly above 10%. That still puts it as the country with the highest vasectomy share of use of vasectomy. You can see in other countries, in China, it is hanging in there at 5%, you might say, and elsewhere it has become almost negligible in the method mix. Third trend that we talk about in the paper is the hormonal method progression that we see in Sub-Saharan Africa. That is to say, countries which at one point had a strong reliance on the pill, as the injectable became more available, their share increased, and now that the implant is there, is now available, we're beginning to see a rise in the implant, similar to what Roy has discussed in his papers. But this is the example from Ghana, and there are several other countries which show a very similar pattern. Also, another good example of how traditional methods have fallen off. So where are we on method skew? That is, having 50% of users or more rely on a single method. Not so great. There has been an improvement over time. When we looked at it in 2006, it was 35% of countries that had a method skew. By 2014, it had dropped to 30%, and now it's 29%. Let me just mention, and I don't think other people are going to talk about Skew per se, but FP 2020 defines that as greater than 60%, whereas we're defining it here as greater than 50%, just for those of you who wanted to feel confused. Okay. Again, there's no one method that jumps out as being, oh, this is the reason we have Skew. The 8 countries have Skew because of the injectable, followed by 7 with traditional methods, and fewer for others. But there's no one single method that's the cause of it. If we look at those 30 countries that have a Skew of greater than 50% as of their most recent survey, we again see this idea of it's no single method. It really is it's spread over 6 different methods. The countries, if you've got good eyesight, you can check on your favorite country here. The injectables and traditional, many of the countries are from Africa. The IUD and Egypt and some of the stands. Female sterilization, interestingly, 3 of the sites, I guess we're calling Puerto Rico a country these days, 3 of the sites are from Latin America, plus our favorite India, and condom in Hong Kong and Botswana. So what is the actionable takeaway message from these data? And this is more or less an adaptation of the model that Trish had put up earlier. As Ellen alluded to in her presentation, it's really a question of both supply and demand that influence method mix. So on the supply side, yes, we do have a method availability. What is the quality of counseling? Provider attitudes, provider bias. How well our clients help to manage their side effects. But on the demand side, there's also action to be taken. Knowledge of the full range of methods. How well do clients come to tolerate these different side effects? And 2 that are really, I think, probably the biggest, would you say opportunities or challenges? This idea of the reproductive desires and the lifestyle. I think that the social marketing people are certainly on to lifestyle in terms of trying to reach populations. And the question of societal norms. You have women that come to the clinic. My sister used the pill. My aunt uses the pill. My friend uses the pill. I'd like the pill. And is this good? Is this bad? Everyone I know uses method X. So how can programs promote method choice to influence method mix? And again, I put up the same issues. There are the supply side. We've talked about some of these points already. I left the box open for what else, because I know that's going to be the talk of today. What can be done to further improve method choice? There is the demand side, improving knowledge, social and behavioral change communication to improve knowledge of the full range of methods, encourage, through counseling, encourage better management of side effects. I put a question mark beside how much can you affect reproductive desires and lifestyle through social and behavioral change communication. And I left a blank beside societal norms. I still haven't figured out how you entirely get away from that. So the question I think to be asking ourselves, either from a perspective of the country, a program, or a donor, is method skew necessarily a problem, especially if prevalence is high? I sat beside the director of the Packard program in India a few months ago, and he just kind of shrugged his shoulders. It's like, this is how things are in India. The second question is, what is the role of donors and implementing agencies in influencing method mix? I think this meeting is all about improving method choice, but are we in the business of influencing method mix? And I think, so yes, we're all here to improve method choice, but if you do everything you can and method mix remains skewed, then where are we? So with that, I'll finish my presentation and turn it over to the panelists. I will not introduce them because in detail, except to say that we'll start with Emily Sondeveld. And each panelist can come up afterwards.
Okay, good morning. So I am going to have some overlap with Jane in terms of the presentation or the graphics. However, we're looking at a slightly different geography. I'm going to be focusing on FP 2020 countries and looking at sort of the maximization of data that's available, which is the goal of the Track 20 project, to talk about how we look at method mix and, for some small examples, how we try to enter into the choice arena. So because method mix is available across so many countries, we actually do quite a bit of analysis to try to help countries and the global audience understand how that information can be used effectively, even if it's not completely related to, even if it's not looking at method choice. So we have a lot of analysis that we can do just based on what women are using. So I'm going to quickly go over sort of the number of methods used in a country, the most common method, and we can look at that at a regional, national, and subnational variations. Changes over time, although in the near term, not the long term, like Jane had talked about, so just between the last 10, 15 years or so, how those changes over time have changed the overall effectiveness of the method mix, whether it's going up or down. And then one quick slide on what we see as the added value of using service statistics in these discussions. So not just surveys, but the data that's coming through country systems. We will then talk about a couple of the core indicators for FP 2020 that does try to focus on components of choice. We understand that that does not represent everything that would need it to be as per Jane's conversation or Jane's presentation, but there is some information that we can use to help understand what role choice is playing in what the method mix looks like now. And then at the very end, we'll talk a little bit about access and some data that's available to look at that, to understand that better and to have a bit of a discussion about that. So if we look at the 69 countries for FP 2020 and we sort of distribute them by prevalence, so we have our lower prevalence countries on the side in orange, we have our sort of mid-range prevalence in the middle, and then our higher prevalence on the side. So there's been a lot of documentation that relates the number of methods available in the method mix to prevalence. Right? There's lots of different surveys that show the different components. And what this is doing is it's showing any of the countries that are dark or have asterisks. These are countries that have at least 5 methods that are showing up at greater than 1% of the method mix. So it's pretty easy, I think, to see directly that within the higher prevalence countries, with just a few exceptions, these countries actually do have 5 or more methods that are showing up in their method mix. And that's actually true also in the middle category, especially if you focus on this column. So the countries are actually listed in the order of prevalence. So our lowest prevalence country being Somalia and our highest being Nicaragua. So it goes down from this column and then here, here, and here. So these would be the higher prevalence countries in that middle category, and the majority of them also, right, have at least 5 or more methods that are available. So we can see that relationship quite clearly. We can also see a little bit of what Jane talked about in terms of skew, that some of the countries like India here that aren't bold and with asterisks are countries that have skew, so they don't reach that 5 method threshold, right? So a little variation, but the message is still pretty strong that more methods is correlated at least to higher prevalence. And another way to look at that same, although in this one maybe we can just focus on the actual percentages, this is looking at the average prevalence per number of methods, right? And the color coding remains the same. This orange would be countries that are in sort of that low growth category, right? So those are all hovering down towards 0 methods. Not sure what country that is. 1, 2, 3, and 4. But what's important here is that the prevalence is clearly increasing in a pretty consistent pattern with the number of methods that are actually available within the system. We have a little bit of wobble here at 7, but it's just because it's very few countries that fall into that category, right? So that message is pretty clear when you look across the FP 2020 countries. So we can also look at the dominant method. So this is similar to something that Jane had talked about, and this is looking at the most common modern method in use. So in the majority of countries, we have about 26. We have injectables being the most common. You see that here in Africa, a little bit over here, followed by pills, which are 17, also kind of running this direction, and sort of so on. The interesting part is we actually do have some countries that fall within long-acting, in some case permanent methods that are the most dominant, although not many. We have 8 IUD countries, 6 sterilization, and 3 implants. The 3 implants are sort of clustered right over here in case you can't see those. So a little bit of change, some variation, but the most common method is pretty different when you look on a country-by-country basis. So I want to bring attention here to this comment that I forgot to delete, that we struggled a bit with how to display all this data on one slide. And we did manage to land on something, as you can see, but it was an iterative process with Jessica Williamson, who works on the Track 20 project. So apologies for not deleting that. I was too tired last night to notice it. So anyway, so we can also look at method mix and compare method mix amongst married women and unmarried sexually active, right? So over here, we're looking at countries where the most common method is the same amongst those two populations. So the most common method, for example, in DRC is a condom, whether you're looking at a married woman or an unmarried sexually active woman. And we have some countries over here where those actually are quite different. So in all of these cases, here you have your most common method for married women, and then condom is the most common method for unmarried sexually active. And again, as Jane said, there's not a right or wrong to this, but the important part of the conversation is that condoms are often accessed outside of the formal system, and as long as that's done as choice and not because they don't have access to the formal system, then that's something to discuss. But many of the countries, you can see that condom falls into that most common method for that population. I think that's my only comment I left in, but if you see any other ones, let me know. Although maybe this one was the biggest struggle. So we can also spend a little bit of time looking at some of the comparison between married and unmarried sexually active for those two different examples where they're the same or they're different amongst the population. So over here, we have Ethiopia and Philippines, where the most common method is pretty much the same between married and unmarried, and you can see how that distributes. So here it's injectables amongst married, injectables amongst unmarried. Same thing here in the Philippines, where this is pills amongst married, pills amongst unmarried sexually active, right? So largely consistent. The rest of the method mix is pretty much the same in Ethiopia, some differentiation in Philippines, but that main method is still driving both populations. So if we look at some examples for countries where they're different, here we have Haiti and Zimbabwe. Here what we can see is for the married women, we have this green, which is injectables, which turns into condoms for the unmarried sexually active, right? So very clear that they're sort of swapping each other out. And then in Zimbabwe, what we have here amongst the married are pill users, and those pill users sort of get split between pills and condoms amongst the unmarried sexually active, right? So some variation, as would be expected, but it's important from our perspective to spend some time with governments talking about these differences and making sure that they don't represent barriers to be able to get the method that they choose. So another way to look at subnational variation, this is from Ghana, and I love that Jane and I both randomly picked a Ghana example. So this is looking at method mix by subregion. And although those same methods seem to be relatively available across all subregions, the distribution is actually a bit different, right? And some of this could have to do with rollout, so maybe implants were rolled out in phases. But there are some that I think are a little bit interesting. So one is the presence of female sterilization that you do actually see in some areas. 16% is not negligible, especially based on what Jane just showed. And then what you also see then is the light blue are implants, where you can see implants are sort of happening everywhere, but maybe in these last three districts they're happening a bit slower, where injectables are still sort of remaining the dominant method that pushes things forward. So some variation, this likely due, right, to how the programs were rolled out and what's available and when it was available in each of the subregions. So if we look at changes over time, within the FP 2020 countries, implants are growing the fastest, right, followed by injectables, and then pills and condoms, very little by little. And then the other, sterilization, both male and female, and IUDs, those are negatives, but barely. They're relatively static, right? So very little movement. And then if we look at by country, what's the fastest growing method, this is sort of divided up by countries where implant is the fastest, injectables, LAM, condoms, and pills. So lots and lots of variation. I think the few that I can point out, since I think I'm low on time, Mozambique is the country that's been growing the fastest within the FP 2020-69, and what this shows is that growth is largely driven by injectables, largely. In contrast to that, I'm sure many of you are familiar with the most recent DHS from Lesotho, which showed this massive increase in condom use, which is being reflected here, right? So you can see that. I'm going to skip that to get through. Just to say that this is the example for service statistics. So basically, the top graph is coming from the country service statistics program, and this is looking at the trend of each method. And this light blue line is implants. Right? So we knew before the most recent DHS came out that implants were sort of taking off in Benin, right? So we were anticipating that we would see a shift in the method mix. Whether or not that led to a shift in the prevalence was an open question, but at least in the method mix we knew that was happening. And so when the survey came out, here is the change in implants. So the HMIS system can provide a lot of information around method mix that is extremely useful, not just towards determining whether or not the implementation of your program is going as expected, but also to give you some anticipation of what you should expect when your survey comes out. So I want to jump really quickly. I just have a few slides on choice. So one of them, and I should say quality of care should be in quotes here because we understand that this is sort of the bare minimum of information that has to be given to a client. So this is looking at the Method Information Index, which is a series of 3 questions that are asked in DHS and PMA 2020, which ask current users, when you got your method, were you told about other methods? Were you told about side effects? Were you told about side effects? And were you told what to do if you experienced side effects? And if you said yes to all 3 of those, you were counted as sort of receiving the floor, the base information that you should have in that exchange, right? So the interesting thing in this slide is that long-acting methods actually tend to score the highest. So implants is actually pretty understandable because of the training that's been going into the rollout. But IUDs is a little surprising, right? So that's something to think about a little bit more. Sterilization and pills tend to score the lowest, with injectables somewhere in between. So information that varies from country to country and definitely varies by method. So just a few minutes on, this is another core indicator for FP 2020, which looks at decision making. And I think most of us are probably relatively frustrated with this indicator. There's very little variation. It's over 90% in most countries. We're not really sure it measures exactly what we want. However, that doesn't mean that doing additional analysis can't tell us something. So what this is doing is looking at that indicator by method. And it's looking at the dark green is the woman herself said that she mainly made the decision to use. The light green says she made it jointly with her partner or provider. And then the orange here says it was mainly the husband that drove that. So what I find interesting about this graphic is how consistent it is across methods, which is pretty surprising. About a quarter of the women are making the decision themselves, the majority are making them jointly, and then you have a few, about 10%, who aren't involved in the decision. And the variation at condom, which actually to me sort of reinforces that maybe this data can be used a little bit because you would expect that to be lower, right? You would expect the woman not to be making that. So some interesting information that we can look at in terms of choice and decision making, and that data is available. And then lastly, this is looking at a slide from the National Composite Index for Family Planning, which was created to try to add some elements of rights and empowerment to the family planning effort score. And it has information that is in addition to just access, but I just wanted to show one graphic. So this is basically from key informant interviews, which asks the percentage of the population that has access to each method. And so what's interesting is that it's not surprising, right? So the triangles here at the bottom are male and female sterilization, least access. The squares here in the middle are IUDs and implants, right? Higher than permanent, but less than the circles, the green circles at the top, which are the short-acting methods, right? So the hierarchy that we expect, right? But I think it still has some added value to showing some of the limitations that women have in accessing some of these methods, which of course is going to influence the method mix. So this is sort of an additional data source, and there's a lot of other information that can be pulled from it. This is just an example if people are interested. But lots of variation, and I think ways that we can continue to try to use the data more effectively, even if we don't have the available data to measure sort of full choice. We can start slicing components and see what we can learn. Thanks.
Great. So my name is Michelle Weinberger, also with Avenir Health. I'm going to talk about some data coming from the Commodity Gap Analysis, which is a reproductive health supply chain coalition report. So this is also going to look at use. So again, kind of that theme of method mix and method prevalence. But we're going to look at a couple different dimensions. So we're going to look at where a woman goes for her method, so the role of different sectors, public and private. We're going to bring in data on costs, so to understand what women are paying and what methods cost, because I think that's an important part of these conversations around choice and availability. And we're also going to examine some geographic patterns similar to what Emily and Jane have shown. So just a very quick point of history. So this 2019 report that I'm going to show data from today is the 5th in a series that dates back to 2001 of this report that has been produced by the Reproductive Health Supplies Coalition. And over this time, the report has really evolved to keep up with the evolving conversations within our community. And so you'll see this year, we delve a lot more into that private sector, understanding the role of subsidy in the private sector, looking at a wider set of countries, all things that kind of keep up with the discussion. So I think much as this group's conversation has evolved, some of the changes we see in this report sort of mirror the shifts in where we are as a community. So the report is structured around 5 key themes this year. I'm not going to talk today too much about number 1 because our spending data isn't disaggregated by method within the report, though of course spending and procurement is a very important part of the picture, and thinking about how what is bought and what is procured is part of, influencing and shaping what ultimately is available and what women ultimately are able to choose. But we'll talk a little bit about a few results from the other 4 themes, looking at the role of different sectors, looking at this issue of subsidy within the private sector, at this issue of costs and understanding cost drivers, and then a little bit saying what can we expect in the coming decade if we look at recent trends. So based on all those patterns that we've seen recently in shifts in method mix, if we extrapolated those forward, where might we be? Before I get into results, just to say that our universe for this report is 135 low and middle income countries, and the analysis is built up country by country. So it's taking into account all sorts of differences, as both Emily and Jane have shown, that exist country by country, but then letting us aggregate those up to tell sort of a global story. Also this year, we do a lot of contrasting across 3 different income groups defined by the World Bank based on GNI per capita. So we look at low-income countries, lower middle-income countries, and upper middle-income countries. And I think comparing and contrasting these provides some interesting insights into sort of differential patterns, but also in thinking about what the role of different actors are in these different settings. So what is the role of donors? What is the role of implementers? The role of private sector, governments, all these different players, because we're likely to shift over time as countries move across that income pattern. And then lastly, to say that we draw on lots of different data to create these country stories. And so we have some of our usual suspects in there of DHS and PMA, kind of household-based surveys, but pulling in a lot of other information to be able to get as complete a picture as we can in terms of that current spending picture, current use, and then informing those future projections. And just to flag that there is the report this year is an online report, so lots of interactive abilities within it. And so this infographic is available in the reader's guide, and you can actually hover over all these different circles to get some additional information on those data sources and how they're used. Great. Okay, so with that, we're going to jump into data. So Jane pointed out earlier the importance to think about the difference between when we look at mix versus prevalence versus rates. So in this graph, these bars sum to the number of women using a method, a modern method, from either the public or private sector. So here we're thinking a little bit more at prevalence rather than at mix. And I think that's important because sometimes when we compare method mixes, if the level of use is very different between those 2 places we're comparing, sometimes, it's useful to look at the difference in the mix, but sometimes that can present a skewed picture as well. So looking at it in that absolute term as well as that relative term can tell us different stories. And the main thing that we see here, and this is across 135 low and middle income countries, is that, unsurprisingly, probably in the public sector, long-acting and permanent methods really dominate, with 67% of women who go to the public sector using a long-acting and permanent method, with the opposite being true within the private sector. So nearly, or just over, 70% of private sector users are using short-term methods. There's a lot of different reasons why this exists, right? You have differences in the levels and types of providers who make up public and private providers. You have differences in legal frameworks around what people are able to provide. You have differences in affordability of methods across these 2 sectors. And you have differences in accessibility of different types of outlets. So again, this is sort of our outcome data. This tells us what's happening, but it doesn't really tell us a lot about why. And so thinking more about what are those barriers, what are those issues, to be able to say interpret what this means. Because I don't think we wouldn't necessarily interpret this as sort of there being an an issue with choice in one sector versus the other, but more that different sectors are sort of able to provide different sets of methods. And I think what we want to make sure is that we're looking holistically, right? So that a woman in a country has a choice of a range of different outlets, and collectively from that choice, she's able to make that choice to use the method that she wants to use. So we do see quite a bit of variation if we look across income levels within the public sector. So this graph on the left shows us, so now we're looking at this in that relative sense of method mix. So on the left, we see the method mix of public sector users. So while long-acting and permanent methods kind of play the greatest share, we do see that within low-income countries, it's actually a little bit less than 50% because there's a very high use of injectables through the public sector in those countries, and a little bit of a difference between the low-income and the upper middle-income countries in terms of what that mix looks like. So again, in both, there is that dominance. Let's see. Get the little light. In private sector, interestingly, we find that in all the different countries that there is still that dominance of short-term methods, and actually the mix looks quite similar. So it's actually a little bit surprising that we don't see so much variation, but again, maybe speaking towards the types of outlets that exist within the private sector mean that across many different geographies and different settings, you have pretty similar utilization of, condoms, pills, and a little bit of injectables. Emily, there was a button that...
The top one across.
There we go. Perfect. Okay. So next, I think we often think about a dichotomy when we think about the private sector of public versus private. But in reality, what we find is it's much more complex than that. So this year in the report, we worked collectively with DKT and MSI and PSI and other partners to really delve into that private sector and try to understand the role of subsidy. So this could be subsidy provided by a donor. So when, say, USAID supports social marketing programs that are providing commodities through private outlets at free or subsidized prices, or in some cases, even a subsidy provided by governments. So example, the government of India purchases commodities that go into national SMOs. And so when we think about the private sector, it's useful to think about who makes that private sector up, because that has implications for access, right? So women who are able to access free or subsidized products in the private sector clearly have different barriers or different accessibility than when the private sector is only made up of full-price commercial products. And so what we found looking at this data is that there's quite a lot of variation by method, but that both IUDs and implants, as you see here, have the most subsidy in relative terms, right? So a larger share of private sector IUD and implant users are using subsidized products than other products. What I should note, though, is that this is a relative view. So actually online, all these graphs, you can toggle between relative and absolute, because in absolute terms, there just aren't that many private sector LARC users, right? And so while there's a kind of much larger relative role, that role is for a much smaller subset of women. The other thing we find, looking by income group, is unsurprisingly or maybe reassuringly of well-targeted efforts, is that the role of subsidy is the greatest within low-income countries, where about 40% of private sector users are relying on subsidized products, which you see over here. And again, online, this graph can be toggled to see how this picture varies method by method. I would encourage you to do a little playing with that, because there are some interesting patterns if, say, you compare implants to condoms. So one thing we do in the report is we actually look at method mix in two different ways. So traditionally, we think about method mix in terms of its manifestation from users. So what share of women are using each method? We also have the ability to look at this in terms of costs, right? And we know that cost is not simply a function of use, because different methods have different costs, and different methods need different units of volume over the course of a year. And if we look at method mix in terms of costs, we see a strikingly different picture. So on the left, this bar shows us use divided by method, where we have a pretty even split between long-acting permanent methods and short-term methods. And on the right, we see this picture in terms of cost, where it's overwhelmingly driven by short-term methods, mostly by pills. So there's a few reasons that this is happening. So first, pills require frequent resupply, right? So even in the public sector, a pill user is sort of relatively more costly than other method users because of that need for so many cycles over the course of a year. That's coupled by the fact that pills are more often sought out in the private sector where prices are higher. So you sort of have a double push of skewing that higher, inflating that cost. And on the flip side, many long-acting and permanent method users don't actually need a commodity in a given year, right? They're relying on a service or a commodity that they received in past years, and so only a small subset of those users have a cost associated with them. So that part sort of deflates. So you have this combination of this inflating of short-term methods and deflating of long-acting and permanent methods that produces this view. And I think this is important, again, as thinking about financing and affordability, right? Because we want to not just think about where users are and what methods they're using, but how do we make sure that the funding is there to support those users and that the funding is distributed in a way that makes sure that women are able to get the methods that they want to be using. And just quickly, in the last minute or two, we're going to turn to the future. So the CGA makes projections out to 2030. I would say these are not meant to be forecasts, right? We're not saying this is where we think the world will be, but rather saying based on everything we know about current trends, where would we expect things to go? So these projections are being informed by two sets of trends. One are projections from FP 2020 and the UN Population Division on changes in contraceptive use. Right? So our best guess of how MCPR will continue to rise, coupled with population changes to get to total users. And then secondly, this is overlaid with changes in method mix that are informed by sub-regional patterns that we're seeing across countries in recent years. And so Emily showed some of these patterns. We see similar here, some slight differences because our universe of countries is a bit different than the FP 2020 countries, but see that rapid increase in implants, which we see almost everywhere. See increases in injectables as well. At this aggregate level, we see a little bit of decline in pills. So again, that varies quite a lot, region by region. And I will say that one thing to think about is that very steep growth in implants, right? That was largely supported by funding from donors and partners, service delivery from donors and partners. And so as we look out to the world of 2030, thinking about what would it take to sustain that, right? So if we've kind of created these method preferences, these shifts in preferences that are driving these shifts in method mix, how do we make sure that we're able to continue to meet those women's desires and needs and choice for those methods when maybe that financing landscape changes or those programs start to shift and look different in different countries? And then just quickly, this graph shows us the same data, but rather than looking in that absolute terms, looking more in that relative terms. So the bars here represent the share of the method mix. So the first bar in each of these shows the method's share of the method mix in 2020. And the final bar shows the share of the method mix in 2030. So those little blocks in between show us the changes over 2 5-year periods, right? So making up that total change over the course of a decade. And interesting, what we find is because of the dynamics of how different methods are changing, is that even by 2030, if these changes were to continue, we'd still have this fairly even split between long-acting and permanent methods and short-term methods, because the increase in implants, so what you see here, is largely offset by declines in sterilization and IUDs, and that decline in pills is largely offset by an increase in condoms. So we have a little bit of sort of rebalancing, right? So that we still have this predominance of kind of 50-50 split, but the methods that make up those long-acting permanent methods and short-term methods are shifting. So just to end, just to plug about accessibility of this data. So the report is available at this URL. All of the tables and graphs are interactive, so you can look at data for a particular country, a particular region, method, sector, where appropriate, and all of them are downloadable as either Excel tables or figures. There's also a country explorer and a data annex accessible at the top right of the screen that let you get this data in more detail for different countries. The country explorer allows for comparison across countries. And then finally, there's a series of 2-page snapshots which present key data on each of the themes. So with that, I will pass it over, I believe, to Rebecca.
Okay, perfect, thanks. I'm gonna see if I can rig it up here so I can. So good morning. I'm Rebecca Callahan. I am with the Contraceptive Technology Innovation Group at FHI 360. And I'm going to mix it up a little bit here and talk about what we know or don't know about what women and maybe men really want in their contraceptives. So this panel is about method choice, but people's choices are limited to the options available to them, obviously. So what do these data on method mix, method availability really tell us about what people want? If we had different, perhaps better options, would people make different choices? And would that lead to better outcomes and happier users? So I'm going to present just a few data from some studies that give us a little bit of insight into this. So historically, I would say our field hasn't approached contraceptive technologies as the consumer products that they ultimately are. For the most part, contraceptive development has been driven by what is technically feasible. And we've certainly iterated on delivery mechanisms, but even those advancements, I would say, haven't necessarily been informed by user preferences. By and large, method acceptability has been assessed relatively late in the development phase of new products, usually with a short survey and in the context of a clinical trial. I think we're beginning to do better as a field, and I'm going to describe 4 recent surveys that my organization's been involved in recently. I'm sure there are other great examples from the organizations you are with as well, and we can talk about those too. So I'm going to spend most of my time talking about this study we completed with funding from the Gates Foundation as part of our contraceptive product development program at FHI 360. We implemented this user preferences study in Uganda and Burkina Faso to gain insight specifically into 6 methods that were in our pipeline at the time, that at different stages of development and introduction. And just really briefly, those were a new smaller copper IUD, the LNG IUS, a single rod implant that would last 5 years, a biodegradable implant, a longer-acting injectable, so specifically it would last for 6 months, and a new approach to non-surgical permanent contraception. So we were fortunate to be able to include a short module of questions in the PMA 2020 surveys in each of these countries, one round of the survey. And then we also did extensive qualitative research, focus groups, and interviews with women and with providers and policymakers. So while this study focused specifically on these methods, we also were able to solicit quite a bit of information about general method preferences as well. So one of the questions we included in the PMA survey is shown here. So we asked, in choosing a contraceptive method, what are the most important things for you? And this was, the answer choices weren't provided. And people could provide more than one response. And so you see here, effectiveness, duration, potential for side effects, cost were mentioned most frequently across both countries. I would point out about a fifth of women in Uganda mentioned the importance of the method not affecting menstruation specifically, and 12% of women in Burkina mentioned being able to use the method secretly. So there's a lot of information on this slide. Really, this is from the qualitative data. It's also related to preferences for product characteristics. We had women in the focus groups order 16 cards that had different method characteristics on them. And what this is showing is the proportion of focus groups in which the cards came out in the top 3. So really the take-home, the important part is in the top blue box there. And I should have said this is for the Burkina Faso sample. The most frequently high-ranked cards were potential for fewer side effects, that their partner approved of the method or liked it, immediate return to fertility, and that it caused regular or didn't affect menstruation. Then similarly for Uganda, the results were pretty much in line with that, particularly related to side effects and no effect on menstruation, partner approval, provider recommendation, and ability to use while breastfeeding. So jumping back to the survey results, we also asked respondents if it were up to them, how frequently would they take their ideal method? So how long would it last? Nearly 60% of women in Burkina and about half in Uganda would prefer a method that lasts at least a year, with the mean being 3.5 years. About a third in each country would choose a method that lasts a month or more, with a mean being just under 4 months. So you can see more than 3/4 of women were interested in a longer acting method. So also in the survey, in the PMA survey, we described each of the 6 methods that we were interested in, and asked if they were each available, would women be interested in using them. And so as you can see here, the greatest interest in both countries was for the 6-month injectable, followed by a 5-year implant. So then finally, we, among the methods that they said they were interested in, we asked which of these are you most interested in, and if they were current or recent users, we said, and also think about your current method. And 75% of current or recent method users said they would actually prefer to use one of these new methods that we described. And then among non-users, 90% said they would choose one of these methods over continuing not to use. So I think this is striking and clearly points to interest in new and different options. So I will now switch to a second study that we completed recently, and this was focused on another product that we're working on, a contraceptive microneedle patch. And just briefly, for those of you who might not be familiar with this, microneedle patches are small adhesive patches with many tiny microneedles that are pressed onto the skin, and then they break off of the patch backing and are left in the skin, where they biodegrade and release their payload, in this case a contraceptive hormone. These have so far been developed for in other therapeutic areas, particularly vaccines, and we're working with a group to develop this for contraceptive indication. So to solicit user preferences around a product like this early in the development phase, we designed another mixed methods study, which we conducted in India and Nigeria. And the study included an initial qualitative phase, again with focus groups and interviews with women, family planning providers. And then we used those data, along with input from the development partner, to design a discrete choice experiment survey to quantify the relative importance of several product attributes. And so that's what you can see on the right side. That's that we used tablets for the data collection, and you can see an example of the DCE. So, and women made choices between the 2 hypothetical products. Just really briefly to let you know what we included in this, these are the attributes and levels. I'm not going to read them all. Just because it may seem a little strange, the locations these were ones that the developer suggested because these are harder places on the body, so like the microneedles would be able to be broken off more easily. Whether that's actually going to be necessary in the final design is still TBD, but that's why they're kind of odd, top of the foot, knee, and okay, so this slide shows the results from the DCE. And we did the study first in India. An effect on menstruation clearly came out on top as the most important product attribute. Women, by far, not surprisingly, preferred a product that would not affect menstruation. That was over either causing amenorrhea or causing irregular menstruation. Duration of effectiveness was the second most important characteristics, and they preferred a product that would last 6 months over something that would last 3 or 1 month. So because we saw this strong, very strong preference for the menstruation attribute in Nigeria, we decided to conduct the survey twice. Once in 2 different samples, one with the menstruation attribute and then one without, so that we might be able to see the other attributes' importance more clearly. So you see that the results are fairly similar to India. Menstruation coming out on top, followed by duration. And then when menstruation isn't included, pain emerges as being more important. Okay, so another example of method-specific research we conducted was related to the longer-acting injectable, the 6-month product. This qualitative research was conducted in Rwanda and Kenya and focused on obtaining potential users' input specifically on the items that were in the target product profile for this product. I'm not going to spend a lot of time here, but just to say that here again we found strong support for a 6-month injectable product. Also, similar characteristics emerged as being the most important to women. So having high effectiveness, ability to use while breastfeeding, and again, ideally a better side effect profile than existing injectables. And then finally, I'll mention some human-centered design, including ideation work that FHI was involved in collaboration with the Gates Foundation in India and in Kenya. And I'm not going to present specific results from this, though you may hear a little bit more about this in the afternoon. I wanted to mention this work, though, as an example of even more upstream contraceptive market research and another way of getting at user preferences and interests. So the goal of the CTI Innovation Lab, as it was called, was to use design thinking methodologies to develop innovative, disruptive product ideas. And this is an ongoing project. And the phase we were involved with was this ideation phase, during which immersive rapid field research was conducted to develop materials known as collateral, which is then used to develop user profiles. So one example of user profile is shown there on the upper right, the coping solos. There were other profiles like the determined dreamer, the conservative romantic, and these were, and several others. They were meant to kind of to show different unmet need characteristics of different profiles of users. So then the goal of the workshops was for the groups of ideators that convened in the two countries to generate blue sky, really out-of-the-box, moonshot ideas based on this collateral information, these user profiles and other context information. And then a short list of resulting concepts was developed, and those are being further vetted into the second stage of the process, or this program, which is still ongoing. So we'll see ultimately what comes out of that. So in conclusion, as I mentioned at the start, contraceptives are consumer products, and as with any consumer product, market research is crucial for developing and making available products that people want to use and meet their needs. What I see as common themes across these studies is that women want effective methods with few side effects, particularly menstrual side effects. Not surprising. But I would challenge us to really consider how we as a community are addressing these preferences. I think we all know these things already. While product developers continue to iterate on duration and delivery mechanism, which are important for things like, self-administration, ultimately, I think, we need game-changing innovation around contraceptive products with new mechanisms of action that truly, help us overcome these long-standing barriers to uptake and continuation. So I think all of these data really point to a mandate for expanding choice. So that's it.
Okay, good morning, everyone. I'm Scott Radloff. I'm at the Gates Institute at Johns Hopkins. I'm the director of Performance Monitoring for Action, PMA, formerly known as PMA 2020. We're in a transition year from our earlier grant to our new grant. It's being conducted in partnership with JPIGO. And so I'm going to be talking a little bit looking backward and a little bit looking forward in PMA. So just to quickly summarize achievements under PMA 2020, we launched in 2013. We've conducted 66 rounds of data collection, mostly family planning focused, across 11 countries in Africa and Asia. We've introduced 6 new survey topics, including nutrition, primary health care, MNH, WASH, abortion, adolescent health, but mainly focused on family planning. We have this innovative design where we train women from their communities, train them to collect data using smartphones for quick turnaround data, and for repeated rounds of survey on a regular cadence. We've conducted over 500,000 interviews to date, and we make our data available within 6 months of the completion of fieldwork, and we've had over 8,600 downloads of our data. So what's new under the next phase of PMA? So a major one is that we're moving to a multi-panel design, but maintaining cross-sectional data. So we looked at our data collection model. We have women in the communities, and we do new selections of households in each round in our first phase. And we thought, well, why not interview a panel of women over time and then supplement it to make it cross-sectionally relevant as well. So we have a panel of households in this next phase with interviewing women over time, 15 to 49 as before. Our SDP facilities become a panel also over time that we'll be tracking. And then we're introducing a client exit interview with phone follow-up. So that also features another panel dimension. We're introducing in our baseline new questions around community norms. Jane mentioned how important societal norms are in shaping demand. We think it differs significantly at community level. Maybe we could look at family level norms as well. We're introducing new measures around quality of care. We're introducing a series of questions around women and girls empowerment based on some qualitative research that Amy Choi had led. We're also introducing adolescent-specific questions to track transition to adulthood with indicators around aspirations for education, career, marriage, etc. I should also mention, I didn't put it here, but we're also introducing a 2-year calendar. So in addition to tracking women prospectively, we'll be looking retrospectively too, and so we'll be able to see, in one respect, see how effective retrospective calendar data are in tracking changes in contraceptive use dynamics. Geographies, we're continuing in 8 geographies listed there, but also plan to expand to new geographies, mostly in West Africa, Benin, Guinea, Togo, and in Pakistan, which would be Sindh province. We also have a separate activity for Ethiopia, which is a maternal newborn health panel, but it includes family planning and particularly postpartum family planning related questions. So this is a schematic of our panel design. For our various geographies, we planned 3 rounds of data collection, annual rounds. It's a open panel design. So in our first round of data collection, we'll be impaneling households and women and service delivery points, facilities. The open part of it has to do with allowing women to age in and out of the panel. So 14-year-olds today will become 15-year-olds next year and be introduced to the panel, and women will age out as well. We're also introducing an open design with respect to migration. So a household moves out of a structure. We'll try to track them if they move within the enumeration area, but otherwise we'll replace them with the household that's moved into the sample. So it'll be a self-refreshing sample. And wouldn't we all like to be self-refreshed on an annual basis? So we have baseline enrollment. In most countries, we'll be doing phone follow-ups with SDP clients, so the SDP is a new feature of that. Our data will be allow a linkage between the household and the SDPs, so the SDPs are chosen as public sector and private sector facilities that serve that enumeration area. So we'll continue to collect annual cross-sectional estimates. I decided not to show much of this. I'll just show one graphic drawn from our SDP survey. This is Burkina Faso. We've been working with the DMPA collaborative in tracking progress in increasing access to DMPA-SC. Over time, I think we're now in 6 countries that we're tracking. So Burkina Faso was one of the first to launch. And as you can see, this is public sector facilities here, private in 2016, 17, 18, 19. You can see over time in the blue, these are the percent of facilities that offer and are in stock. You can see the stockouts in red, and then these are the facilities that don't offer DMPA-SC. You can see it's public sector dominated, and you can see over time that the access increases each year. Private sector increases more slowly in accessing this method. Also, sticking with Burkina Faso, trends in not method mix, but method prevalence. Over time, we see from 2014 to 2019 overall increases in overall contraceptive use, and you can see the different components of that expansion of use. Implants, as we've seen in other slides presented, has become more widely available especially in Africa, and injectables are also a dominant method. With DMPA-SC, you can see increasing in use, and possibly at the expense of DMPA-IM. So we're about to launch our panel surveys, but in advance of that, we decided to take a look at one country, Uganda, to see if we could go back in time, try to find the women we interviewed in 2014, and we found many of them 4 years later, and we have questions introduced on to identify changes in demand for family planning, unmet need, and use of methods for spacing and limiting. And so if we didn't have panel data, we wouldn't see these streams in between. What we would see are these cross-sectional bar charts. So we'd look at that and we'd say, well, women having no demand has declined by whatever that has 7%. Unmet need has gone down in the case of spacing methods, and gone up in terms of limiting, unmet need for limiting, and then use for spacing and limiting have both increased over time. But we wouldn't know how women got from this to this. So this is a sand key chart that allows you to trace the women and their changes over time. And what you can see, we've often talked about this, that we understand there's a lot of churning in contraceptive use, that women don't just stick with one method, they actually switch methods. And they go from use to non-use. They go from long-acting to short-acting methods. And this allows you to trace that. So in this instance, we find that 53% of the women changed their contraceptive use status with respect to these categories over time. So there's a lot of churning. So in future analysis, we'll be able to better understand why women switch methods or go from use to non-use. So this is an analysis that Amy Choi has done also with the data. So it's the same data from Uganda, the 4-year follow-up. So we look back in 2014 at what women told us about both their unmet need for family planning, or what we can calculate from what they told us from the survey, and intention to use in the future. And we can track women over time to see what happens to women who say they have an unmet need or no unmet need over time. And when I first looked at this graphic, I thought, did we switch the lines here? Are these the right lines? Well, it turns out that women who expressed no unmet need were more likely to adopt more quickly over time. This is time to adoption in months. And so they're more likely to adopt over time than women with an unmet need. So unmet need may be useful for various purposes, but maybe not for predicting future use. As opposed to intention to use, so if you ask the woman, does she's not using, these are all non-users at the starting point, but are they intending to use in the future? And this seems to be very predictive. If they say they intend to use, they intend to use. So maybe looking at what women want or say they want versus what we define as what they need is maybe useful. And this just puts the two of them together, the cross-section of them. So the most rapid increase in use are women who say they have no unmet need, but they intend to use, followed by women who say they have an unmet need and intend to use. And then these other two that are no intention to use, much lower rates of uptake. So just as an example of what panel data can reveal that you may not learn from a cross-section. This is my last slide, I think. So I mentioned that we plan to do client exit interviews with 4-month follow-up by phone. And we've been doing this in a set of countries, 6 countries, I believe, and 13 municipalities under a program called PMA Agile. So PMA Agile, instead of using the household as the primary sampling unit, uses the service delivery point as the primary sampling unit, but then conducts client exit interviews and then follows them over time. And this is based on some work that Phil Anglowitz has done in Kinshasa, where they've followed up with women on a 4-month basis. And we created a sand key chart, again, just to track women who, from non-use over time, whether they adopt 4 months later, whether they discontinue from long-acting or short-acting methods. Anyway, we can track that. You can see, again, even in a 4-month period, there's quite a bit of churning. Women don't maintain their status often. So women, most women do stay in their current status, but there's much churning. And the biggest shifts are in 45% of short-acting users discontinue in 4 months, and 22% of non-users shift upwards to a short-acting method. So even in the short time period, we see a lot of change. So Phil did some regression analysis to determine what are the factors that determine whether women would continue to use. And he found that women continued to use if they said that cost was not a particular problem for them. And then the reverse would be true. They would discontinue if cost was a problem. If they received the service from a higher level facility, they were more likely to continue. If they heard about family planning on the radio, and maybe to say that in Kinshasa, CCP has a radio campaign that's quite popular, and so we think that's driving continuation potentially. If they were more educated and wealthier, they're more likely to continue. If they're not married, they also had more likely to continue with their method, interesting. And distance wasn't a factor, but of course this is at an urban area where facilities are fairly, aren't so distant to most women. So we think this could look differently in a rural area. So maybe in short, PMA will continue to track cross-sectional indicators as before to continue tracking progress in performance. We'll be tracking method availability shifts, method mix shifts and trends. But we will also include this panel that will allow a better understanding of contraceptive use choices and how it's influenced by demand, supply, community factors. And I think agency is another factor that we may find to be very influential, that it's not just women's own demand, but how confident they feel in being able to make choices for themselves. That's it. Thank you.
Thank you to all the panelists. Let me make a couple of announcements here. Please, panelists, squeeze your chairs together there. If you have any questions and you're in the room, please go ahead and write them on a card and pass them toward the back. Or Leah's right here. If you're streaming, please put the online participants, you can chat into the box on the screen. And one final point, we will be taking a 20-minute break after we complete this panel in approximately 25 minutes. So, I think all of the panelists now have their cards, and I'm going to take the prerogative of the chair to avoid doing mine first and instead ask Emily to begin the question and answer.
Sure. Okay, so I have two questions that made their way to me. So one, is there evidence of women using emergency contraception as a routine method? So I should have pointed out that in one slide, there was one block that represented EC. So very minimal, but it is starting to come out little by little. In terms of it being used as a routine method, that's where the real trouble, I think, starts in terms of measurement. From a few different perspectives. One in terms of what she's willing to report as routine, whether she sees it as routine. But from other sources, we can see some of the prevalence. So, for example, in PMA 2020, in addition to asking current use questions, I asked if they've used EC in the last 12 months. We do see a very big difference between those two responses. And then just recently, we've come across 3 countries that collect specific data related to EC in HMIS systems. And so we're going to start looking at that a little bit to see how we can use that to try to make the picture a little bit clearer. So the answer is we're not really sure. The data's not great on it, but I think we have a few entry points to try to figure out how to make that situation a little bit better. And then the next question is about condom use in Lesotho. Why the big jump? No idea. So if anybody has any thoughts on that, I'm happy to hear it as well. It's on our list of things to do in terms of research, but we haven't gotten to it yet to see what's really driving the change. Just know that it was really big. Sorry.
The HIV prevention efforts?
Assuming, but we haven't looked. Yeah.
So we'll just go, I guess.
Please, Rebecca.
Okay, so my question here, were you able to break down menstruation question to those who didn't want bleeding changes versus amenorrhea? And we did it in the qualitative portions of both of the user preferences study and the one specifically around microneedles. We talked a lot about this, and across the board, irregular bleeding is the least preferable. Again, it's not surprising. Amenorrhea is, to some, it's seen as a benefit. To others, it's still something that they're not interested in. At the risk of stealing my colleague's thunder this afternoon, we did include one question in the PMA survey: would you use a method that causes amenorrhea, essentially? And we got surprisingly high levels of positive responses. So it was something around 40% in Burkina or 60%, something like that. It was pretty high, but you'll hear more about that later this afternoon.
All right. So I have a couple of questions around costs. So I realized I did not do my due diligence in talking about what cost data I was showing there. So because the commodity gap analysis is really focused on sort of the supplies perspective, our costs are really narrowly focused on commodities and the associated clinical supplies. We estimate within sort of a public sector context that probably represents somewhere around 20 to 25% of total spending, right? So what you would need to tack onto that to think about full expenditures is your service provider time to provide the service for IUDs and implants. That would include both the insertion and the removal, as well as then your kind of upstream program costs. So we're looking at just that slice. I will say, however, that for the private sector, we're evaluating the cost at what clients pay at point of delivery, right? Because the idea is to think about sort of where are the barriers to funding supplies. And on the client side, it's really the ability to pay for that supply. So that cost is sort of inclusive of all those upstream costs, right? You can't really tease out what you're paying for the commodity itself versus what you're paying for all the other pieces. So it's a little bit of a hybrid in terms of cost there. I also got a question about the increase in condom use. I can look back and see, we modeled our changes in method mix separately for married and unmarried women. I believe that in some regions we saw those increases in both of those populations. So the question was whether that was driven by increases in unmarried use, but that we do see some places where both where condoms are increasing within the method mix in both of those groups. And so it's probably a combination of an increase among both married and unmarried women. And then, sorry, I had one more. Asking about to what degree the CGA looks at availability of products and especially quality assured products. So we're really looking at, in sort of that nice graphic of the framework of method choice, right? We're really looking at the output. Ultimately, we're drawing from survey data of use. So we're not able to really pick up sort of the role of the supply chain in determining that. But I would say there have been a lot of really good discussions, though, about especially looking at different countries, what products are getting to those women, right? And we delved into that a bit in looking at that role of subsidized and non-subsidized products. There's lots of great data coming from the facility side that I think can help us look at that a bit more. So, for example, we drew a lot of data from FP Watch, which was conducted by PSI, which looked at, what types of products were being offered in facilities. They even looked whether those products were quality assured or not. There is a surprisingly high number of products, especially for pills, but also for other things, showing up in that survey, many of which are not WHO pre-qualified, right? So thinking about there is a huge mix of products within what women are using, and I think that's an important piece to this conversation, to think more on that supply side of what's getting there.
Okay, my question is, do we have data on how many methods a woman uses over her 30 years of reproductive age? So I think that's something you could piece together from data on different age groups, but we don't have continuous data for 30 years. The DHS does a 5-year calendar. I don't know, is Sarah Bradley here? She's been doing some analysis of that. And the problem with retrospective data is you get a lot of decay and recall problems. So even 5 years creates a challenge, but going back beyond that even more. So we're sticking to a 2-year calendar. And so, as I said, we could piece that together. And then the other question is, what are the factors most important for behind method switching? And that's something I think Phil has actually started looking at, but I don't have that at my fingertips, what that is. He's been looking at it with respect to the client exit interview data. And again, what I've shown you here today is pretty recent, like just in the last couple of months we've pulled this information together. So still a lot more in-depth research from the data.
Thank you. I have 2 questions here, one of which is, I see a few countries with increasing traditional method use. Why might this be? And the questioner said, I think less access, but we're interested in knowing your thoughts. I think there may also be some ambivalence or I don't think we measure traditional methods with the same clarity and conciseness that we do modern methods. And I'll use Kinshasa, DRC as an example. They have a nice linear trend line where modern contraceptive use moves up in a monotonic fashion. Traditional method use kinds of bounces around, and I think that might be another reason that we don't see quite the same precision in the method in traditional method use measurement. So the second question is, how might we reframe our discourse on modern versus traditional when we recognize that traditional methods are user-controlled and self-care is increasingly recognized as a way to meet reproductive choice and to leverage self-use methods where desired to alleviate health systems? My presentation with this emphasis on traditional methods is what you can measure in a DHS or another kind of nationally representative survey. And it does not capture the standardized method, for example, which is increasingly part of method choice. Equally so, the LAM, which is being promoted, but you saw the reasons why it was not included in this kind of a presentation. So I think that we're on 2 different tracks here. One is what we can measure well, and another is what we might want to be doing in terms of expanding choice. So I'll pass the microphone down the line again. Emily?
Okay, so I think just 2 quick questions for me. The first one is, did the condom use look at dual protection, especially in high prevalence countries? So the last systematic analysis that I think I know about that we did for dual protection was when we updated the CYP factors that Trish talked about in the beginning. So that's pretty old. So, so the answer is going to be no, not in recent years. Although I can say that when we did the update for CYP factors, the dual use was not all that significant across the board. So whether that's changed or not, I'm actually not sure, but it might be something worthwhile to look into. And we can put that on our list and see if people are interested in that. The next one is the age disaggregated data for method mix by marital status. So for unmarried sexually active, we do disaggregate by age, and some of that information is probably available on our website. If it's not, you can send an email and we can send it out to you because we do look at it. Just because the definition of unmarried sexually active, it's skewed a lot towards the younger age groups. So it doesn't end up having the full 5-year age groups that you hope. Although in some countries you get kind of some interesting and maybe potentially surprising by the ever married groups. Where we haven't spent tons of time doing the disaggregation by age for that, but we have looked at it by the ever married category, which I imagine probably falls into the older category. So maybe putting those together, we would have a bit of an idea.
Let me just break in to ask our panelists to please speak more slowly and clearly. Thank you.
Sure.
Upon the request of an online participant.
That was it.
Okay, I got another question about menstruation. Women care about menstruation. They really care a lot. I mean, that's going to be my answer. I would like to understand more about the interest in Ugandan Indian women having menstruation as a criteria for a method. I assume this means Nigerian and Indian women in the DCE survey. It actually wasn't something we originally intended to include in this in the DCE. It was not a characteristic, the side effect that the developer was interested, or something we thought that we could even affect, because it's the whole plan is that it's going to be a progestin in this delivery mechanism, so it's going to cause bleeding changes. But when we did the focus group discussions, it just came up over and over. Women were like, we'd ask them all these questions about the different characteristics that we were interested in. And then at the end, they'd say, well, okay, that's good, but it sounds great. We really like this idea, but is it going to cause the same side effects as, these methods that I'm already familiar with? It just came up over and over. And specifically, they'd ask about menstruation. So, again, the point of doing the qualitative first was that we define what's important, and then we include those characteristics in the DCE, which is what we did. So, again, take-home message. This is something that's important. We need to figure out how to address it, and it's going to come from multiple angles, not just new product development, but service delivery across the board. Anyway.
Okay. My questions are flooding in right now, so I was the last presenter, I guess. Okay, let's see. Have you looked into any substantive differences between DHS retrospective calendar data versus PMA panel data in terms of discontinuation and switching? If I understand this question correctly, so the only place that we've done this a calendar and panel follow-up is Uganda. And I'm not sure that we've lined that up with DHS. We could, I guess, with DHS data to see. And actually, I could say that I could have presented the graphic here, but our calendar that we did in Uganda in 2018, looking back to 2014, we did a 5-year calendar, but the first 2 years of it actually matched fairly well with our own PMA data, our annual survey data in terms of contraceptive prevalence, which gives us confidence that we can capture in a 2-year time period fairly accurately what women are shifting in methods. What was I going to say? We are, I should add that we're doing a collaboration with the DHS team to see whether we can make improvements in the way that we collect calendar data using paper recordings and then transferring it to the phone or to the laptop computer. Another question on, will adolescent questions concerning plans, desires be asked of adults in a retrospective style? And my answer to that is no. I mean, one reason that we're doing the 15 to 19s is that they tend not to, our interview time with them is very short because they don't have much of a contraceptive history or have births to talk about. So we thought, why not introduce questions to the 15 to 19s that relate to experiences they've had to date that may be informative about transition to adulthood. So we've kept it to the 15 to 19s, but we are going to be tracking the 15 to 19s over time. So the 15 to 19s today, 2 years from now, will be 15 to 21s, and then hopefully the panel can continue beyond that, and we can track over time. How are we doing with time?
Keep going.
Okay.
Slowly. Use your special English.
Does your survey take into account costs as a barrier to uptake in use and non-use? Yes. And I mentioned that in the case of the client exit interviews, costs seem to be an issue for continuation and discontinuation. I should mention that while distance wasn't found to be a factor here, when we look at the Uganda panel data, distance does seem to be a factor that affects contraceptive use. That's it, I think.
Thank you. One question was, what do we, as a community of experts, think about the minimal and declining availability and use of vasectomy? How do we include it in the method mix to increase choice? Was anyone else at the 1983 vasectomy conference in Sri Lanka? There was a lot of talk about this then, and I'm not sure we've made that much progress since then. One question one has to ask is, in the day of method choice being a reflection or trying to offer clients what they most want, there is this tension between what the supply environment and folks like ourselves think should be happening in a country and what clients most want. So I'm going to leave. Did you want to ask something? Scott, were you going to jump in on that? No. Okay, good. Would anyone, I don't know if we have audience participation here, would the person that asks the question like to answer it? Okay. No audience participation. We're very dictatorial here. Oh, the audience can participate with the mic, apparently, afterwards. Okay, we're coming down the home stretch. I think we've got a couple more questions here. Emily, and it's between you and Scott on this one, but why don't you start?
Okay, so this first one, Scott, is to both of us, and it's asking about, given what Jane said about the continued use of traditional methods, is there any plan to collect information or do analysis around traditional methods within Track 20, FP 2020, or PMA 2020? So very good timing on a question on our part. There is going to be a special analysis on traditional methods linked in this year's FP 2020 report. So we have been going back and looking at sort of relating the changes that we're seeing in modern method use and then what's happening sort of on the traditional method side. So a bit late to the game, but coming this time. So there will be that will be released, as well as I think a paper that we have that's going to come out and some additional analysis on both of our websites. So that'll be around. And then Scott, I'm going to answer one more before I pass back over to you, because this one's quick. This is actually looking at dominant method and skew by age group. Youth versus older. So it sort of falls into the same category as before, is that we have a lot of the data, we just maybe haven't put it up and shared it. So we'll do that since there's a bit of an interest that we have looked at that. Not across all countries, but many. So Scott, with traditional.
Yeah, so in our first phase of PMA, because we're a quick turnaround survey, we wanted to keep our survey instrument fairly short. And one of the things we dropped that's traditionally done in a DHS is questions about method awareness. So in our first rounds of our surveys, we didn't have method awareness, and that precedes questions about, are you currently, you or your partner, currently doing something to avoid pregnancy? So we've found in our first rounds that our modern method use estimates were fairly equivalent to what the DHS is collecting, but we were falling short consistently across all the countries in measuring traditional methods. So we introduced the awareness questions, and in the second round we saw an increase. So we have looked at better defining that. I think we're still lower than the DHS with respect to withdrawal, I think. Or I'm sorry, no, with rhythm, I think. Anyway, we need to do a little bit more better training on that method in our survey.
Scott, I'm just going to jump in on that. On the two-pager for the PMA 2020, it is, however, based on modern methods. And I think, am I not correct? And the reason is, I understand that so few, relatively few countries have enough traditional methods to make a difference. But I think that if you do work in a country that has a large traditional method mix, this becomes more of an issue.
Yeah, I mean, we do include tracking of all method prevalence and modern method prevalence together. When we do analyses like percent of demand satisfied, it's demand satisfied with a modern method.
Mm-hmm.
Okay, I have a question here. It's either from Trish or for Trish. I think it might actually be for you, but either way. It says Trish, so. Wouldn't meeting reproductive intentions as the new method choice definition better focus us and programs on delay space limit? Is that a question from you, or? So, okay, then it's for you.
So, reproductive intentions are traditionally defined as delay space limit, but they can be also defined by time frames. You know, I want to delay until I finish college, or, till I get married, or space my kids, 3 years apart and 4 years apart, things like that. So there's different ways of sort of digging into that with your clients to really help them make those choices around, or better understand what options might best fit those choices with respect to that particular intention. Now, there's other factors as well that go into that decision making. So,
this final question here is that I mentioned overall decrease in the use of traditional methods, but recent DHSs show an increase in the use of traditional methods among women in higher wealth quintiles, urban, and high education. Can I comment on this? There's one train of thought that says certain women that probably have more agency, precisely in those categories, are wanting to take more control and also not have any hormonal effects, the methods from hormonal effects. Is this the reason? I think this is one of the hypotheses. I think this is one of the reasons we are currently looking more closely at traditional methods to try to understand. I would have said a couple of years ago, we considered this a throwaway category. That is to say, this is what you do when you don't have access to modern methods. And yet we're understanding that traditional methods are here, there's great persistence in their use, and that we do need to better understand what is driving this. So I'm not, for whoever asked that question, I hope you will offer your answer, which is probably going to be better than mine. Have we arrived at the end of the question and answer session? Let me thank all the panelists for this very stimulating set of presentations. Great questions from the audience. Thanks from those online for participating. And we'll now take a 20-minute break.
So I want to formally introduce our next moderator, who is Martin Smith from FP 2020, the executive director, and someone that probably 99.5% of you already know, but I just wanted to welcome him to the podium and have him introduce the next panel.
Thank you very much. I wonder who those 0.5% are. I think you're being a bit generous to me, actually, but thank you very much, Anne. So welcome to our session. What components are needed to operationalize increased contraceptive method choice at the country level? As many of you may know, 38 of the 47 FP 2020 commitment-making countries have made very specific commitments around expanding method choice in their particular context, drawn from the original set of countries at the July 2012 summit all the way through to the latest commitment maker the Gambia, who announced their commitment as part of the UNGA event in New York last night. So this panel session really seeks to draw lessons from key country experiences to really unpack the conditions and the environment that need to be met to facilitate that method choice expansion. And we specifically want to explore, as part of our panel session and subsequent discussion, what components, be they leadership, regulatory, financing, service delivery, the demand side, and so on, what components need to be in place to really deliver on the expansion of that choice. We will, of course, highlight much of the diversity in terms of populations and settings that are there that we've seen in the data panel that preceded us, and we want to bring out some of that context and yet come together with some important lessons, some important conclusions that come out of this country experience. So we're very fortunate to have an excellent panel of 4 along with me for this session. Aparna Jain, the Deputy Technical Director of the Evidence Project at Population Council, Dr. Gitari Ndarungu, the Technical Director from JPIGO in Kenya, Dr. Mengistu Asnake, the Senior Country Director from Pathfinder in Ethiopia, and Mary Jane Lacoste, Senior Program Officer at the Bill and Melinda Gates Foundation. So let's give them all a round of applause, please. So what is the format? Well, before I talk about that, I should remind myself, and indeed everyone involved, that we have been asked to speak slowly during the course of these sessions. So my enthusiasm sometimes gets the better of me, but I will attempt to do that. And I'd ask our panelists to do the same. The format, we will have between 8 and 10 minutes from each of our 4 esteemed panelists. We'll then have a swift follow-up question for each of you in a sort of quick-fire 1-minute round when we all take a seat and gather as a panel in those comfy seats. And throughout the conversations and throughout the sessions, please be getting your questions down on those cards. I think that worked really well last time. Get those questions on the cards for those of us who are in this room. Get your questions in the chat box for those who are online, and they will be transferred to cards as we go along. So thank you very much for that. So without further ado, I'm going to hand over to Aparna. We're keen to understand, Aparna, if the introduction of new methods does indeed lead to improved quality of care, and to understand what we know about switching and continuation in that context. So over to you. The podium is yours, and you have 10 minutes. Thank you.
All right. Well, good morning, everyone. Thank you, Martin, for that introduction. So today I'm going to talk a little bit about some work that we've been doing in India looking at method choice among reversible contraceptive users. So just to set the context, this morning we heard quite a bit about method mix and method choice. One thing that I just wanted to raise is, can method mix be an indirect measure of method choice? So from Jane, we heard that female sterilization method skewed experience in India. What does that actually mean? Could it mean potentially that this could be because no other methods are available in the program? Or could it be that women are just not offered a choice when she's selecting a method? So in response to what the Indian government has seen in terms of this method skewed experience, they've wanted to improve the basket of choice, of method choice that's available by increasing the number of methods, including injectables and the IUD. But then method mix can also be balanced, whatever that may mean. And what does that actually mean in terms of choice? Even with a so-called balanced method mix, women may not be still receiving choice. So I think it's important that when we think about method choice, we actually ask women themselves whether they've received a choice for family planning. So there are a couple of measures that are being used right now to operationalize method choice. The first is the Method Information Index, which is something we heard about from Emily this morning. It consists of 3 questions. Were you informed about other methods? Were you informed about side effects? And were you informed about what happens if you experience a side effect? I guess the question is, what happens when a woman actually receives all of this information? She experiences a side effect. She takes the advice of her provider and does what he suggests or she suggests in terms of how to manage that side effect. What are her options if she still wants to prevent an unwanted pregnancy? Are her options to discontinue contraception altogether, or does she have the possibility of switching a method? So me and colleagues at the council, what we've started looking at is this measure called MII+, where we're looking at adding a question where you told about the possibility of switching to another method if the method you selected was not suitable. And that really enables women to decide and make choices about not just when they want to start using a method, what method they use, but what if that method is not suitable? They can discontinue it and they can switch to another method. And what we've actually been able to show is that the MII Plus is a better predictor of MII alone in contraceptive continuation 3 months later. This method switching question is something that we're working with DHS colleagues to add in the next round of surveys. And I believe Scott can confirm if it's part of the next PMA survey as well. So I'm going to actually skip the MII and go right to the MII+. So just as background, we conducted a longitudinal study in India with reversible contraceptive users. We interviewed them at 4 points in time, when they adopted a method, 3 months, 6 months, and 12 months follow-up. And we interviewed women in Haryana and in Odisha. At the time of method adoption, we asked women about the quality of care that they received. And that includes here, as you can see, the MII+. It's really important to note that at the time of the study, which was in 2016, the Indian government was introducing new methods. So both the IUD was being rapidly scaled and the injectable. They had just said that they would allow the injectable to be rolled out in district hospitals and in medical colleges. But at the time of our study, that hadn't been implemented fully, so we ended up recruiting injectable users from NGO facilities. And so you can see PPIUD and IUD users were from district hospitals, and pill users were through ASHAs, or the community health workers. And here you can see with the MII Plus that by and large, PPIUD users reported receiving less information around the method that they selected compared to other method users. And when you look at the MII Plus, regardless of method, the entire sample that we had, less than 50% reported receiving complete information on the MII Plus. So I wanted to also mention, though, that method choice is within the context of quality of care. And quality of care, as Emily said this morning, consists of multiple domains, which include method choice. It includes method selection, so understanding what a woman's fertility intentions are and what her experiences are using a method previously and her preferences. In the family planning counseling, also providing information around what contraceptive method she's selected and what are the side effects, how to manage them, and the warning signs. Finally, continuity of contraceptive care, including the possibility of switching and respectful care, visual and audio privacy. And so again, you can see here across quality of care measures that by and large, the PPIUD users were reported receiving less quality compared to other method users. And for different items, you can see that it ranges, where pill users tended to report higher levels of quality, and injectable users also tended to report higher levels of quality, especially among the respectful care measures. So I think one thing to also consider is that when new methods are introduced, we should consider introducing them within a basket of choice and not just as an individual method that's being introduced as a standalone method. This not only enables women to switch methods, but it also ensures that women aren't just transitioning or kind of switching from one method that they're currently using to another without necessarily increasing choice. And I think the last thing I just want to end with is to say that instead of finding women appropriate for the methods, our job is really to help women find methods that are appropriate for their needs. Thanks.
Thanks very much, Aparna. Great. Excellent. And we'll have a couple of follow-up questions for you, Aparna, but thank you so much for setting the stage in terms of quality in the India context. So, Gatari, we're getting your presentation up right now. Great to hear about the shift towards increased LARC use, and we're particularly interested, I think, to understand if that results in greater continuation. And I believe you're also going to share some of the early experience on LNG IUS introduction with us as well. So over to you, Gatari. Thank you.
Thank you, and good morning, everyone. Of course, it's exciting to be here and be able to sort of to take us through what Kenya has been able to experience. As you saw in the earlier slides in Jane's panel, Kenya is among on the S curve that is really on the higher part of the scale. But you also do recognize when you granulate that data down to the subnational level, there's a lot of variation. And just allowing us to be able to appreciate and understand the geography helps us a lot to be able to identify what are some of the contextual issues that we need to be able to address. But Kenya has also, having also, improved dramatically in terms of modern CPR, we've also begun seeing an interesting shift towards long-acting and reversible contraception. But like the data were presented earlier in the morning is that, the big one, DMPA, or the injectable, which is predominantly DMPA, still is the biggest method that is used by most of the women in that country, just like in the rest of sub-Saharan Africa. And we were very relieved when the echo data did not demonstrate any increased risk of HIV acquisition, because we knew what that would have meant to the FP program. But having said that, having that trajectory, or that has been gained through gaining a lot of traction with the political and policy makers having bought in, and also being able then with technocrats to be able to guide the sequence of events. I just want to point out that this stagnation between the DHS of 1990 and 2008 and 3 was more related to the HIV pandemic that then resulted in diversion of resources or attention towards HIV. But subsequently, the FP program has recovered, especially with integration and realizing the need to be able to take it everything holistically. I think also wanted to point out here that while we are seeing, the injectables really representing just about half of users, married users, is that you're also beginning to see the other methods like, we've already mentioned implants beginning to take a huge part of that composition. And of course, there are a lot of efforts towards that. And I think the pricing was also an important element, especially the volume guarantee that then led to that. And you begin to ask ourselves, newer methods, are we in a position to be able to begin that kind of advocacy at the global level, so that then we can expand method mix and, of course, choice. I think I also wanted to point out that because we've seen a little bit of sliding female, voluntary surgical contraception, BTL, and again, a bit of circumstances that happen in the country where Dr. Mago used to teach many years. During the severe acute respiratory syndrome pandemic or breakout in 2003, the ambulatory, BTL clinic that was, unfortunately was taken over by, as an isolation ward for victims of the disease. But unfortunately, that did not, it has ultimately eventually was not taken up. So what happened is a huge number of doctors who are being trained and paramedics did not ever get an opportunity to even see how a mini lap BTL is performed. Similarly, when they came back for their OBGYN specialization, they never get an opportunity. And that meant we have a cohort of, clinical people who have not had an opportunity to see interval BTL being performed. Just to go back to LARC and basically looking at implants, you've seen, like we said, you've seen a huge increase in terms of uptake, but also we are beginning to see, of course, removals, which is expected. I think this mainly focuses a lot on both the single and the two-rod implants, but you're also beginning to see removals, of course, with numbers. These are absolute numbers. Unfortunately, we do not collect that data in a DHS. But we also do recognize that IUDs, in terms of their insertion and removal, have sort of not really increased dramatically, or rather remain sort of a little unimpressive. But of course, there are different circumstances. Sometimes it's basically the provider bias in terms of, again, ability of skills, and also the impression that it takes too much time for them to finish with one client. But quite often when you engage them and they appreciate the fact that once a woman gets an IUD, she's out of circulation in terms of routine care for quite a long time period, and then that person, that provider is able to continue providing other services to those women who need them. But I think we also beginning to ask ourselves, especially with uptake being so high, is the other element of quality of care, and especially counseling. And I think we, as a country, we are beginning to ask ourselves, how do we improve that so that then women do not come back asking for removal soon after insertion of a long-acting reversible method. I think just to point out that we are using the recent sort of expansion of LNG-US to the public health sector, a method that has been available for a long time in the private sector, but beyond the reach of the majority of women, especially who access services through the private sector. And having, been able to see the fact that method availability. I think we did see that, and we really appreciate ICA Foundation for having made this commodity available for us to use. But a lot of leadership and advocacy with them, joint planning with the Ministry of Health. This was started off as a study with MCSP, and it has taken a bit of a life of its own, and we want to see how it evolves going further. I think one of the things we've really appreciated is the fact that Learning Resource Package, they've incorporated LNG-US as one of the modules. And indeed, in the FP Guidelines revision of 2015, that were published in 2016, also included LNG-IUS, a method that had been there but was not recognized so in terms of having it in our guidelines, because the number of women that were accessing it was really insufficient or assumed for the rest of the healthcare workforce. Then, of course, making sure that indicators are incorporated into our tools, and we have tools that right now able to disaggregate the type of hormonal, the type of IUD, hormonal versus nano-hormonal, and of course intensive training, working with mentors, utilizing mentoring as our foundation for transferring knowledge and skills. And of course, we cannot forget the user, and I think we'd want to place the user in the center of everything that you're doing. All the things that we heard this morning, and of course appreciating the role that they are important in making those decisions. And of course, we did talk about quality of services, and now we are at a stage where we are seeing an excitement, where we are seeing potentially an interest in scaling up the method through other organizations. Of course, the government taking leadership, and even at the subnational level, other elements of the subnational governments being able to show interest. These are small numbers that we have been able to report, between the time the study was taking place. But we did see that just about 1,500 women accessing the method. It may be a small number, but in terms of providing additional evidence for advocacy and for generating that excitement to see whether you're able to take it even further. And especially one of the things that we're really interested in is how, outside the study setting, how does it fan out? How does it move forward in terms of especially government ownership? And you begin to see that coming out very interesting in terms of one county government being able to actually show interest that they can actually accept the method from ICA Foundation and manage it on its own without necessarily significant support from implementing partners. I think one of the, like we mentioned, the user, making sure that they're in the center of all this, making sure that then we are also able to generate and excite them in terms of demanding methods that are available immediately, they are available in high-income countries. I think that's one of the things that we really would wish to see, so that we are also creating an element of social accountability, and you're demanding from our leaders and decision makers to avail some of these commodities once they are available. I think, of course, one question we keep asking: how do we learn from the HIV sector, where as soon as an antiretroviral method drug is available, is manufactured and is shown to work, it is quickly availed in many of these countries, and we are asking ourselves, are we able to generate that kind of interest or noise, basically, to be able to be heard a little more loudly than we have? I know family planning, or contraception, until we take it out there so it becomes a common conversation, a regular conversation, it becomes a little more difficult for us to be able to move as fast as we would want. Of course, among you, I would also want to include men, especially in our settings or in our context where men are such important decision makers. How do we then engage them to be able to support those decisions that are going to be helpful for themselves and their family? I think I'll stop there, but I'll be happy, of course, to take questions.
Thank you. Thank you very much, Gathari. Excellent. And so moving within East Africa from Gathari to Mengistu. Mengistu, great to have you with us. As we know, Ethiopia's method mix has been traditionally looked to be quite dominated by injectables, but the recent mini DHS shows that changes is afoot, particularly in LARC usage, and changes as well in the equity of usage across wealth quintile. So very excited to hear your 10 minutes. Thank you.
Thank you, Martin. Good morning, everyone. I'm very happy to be here to share the experience of Ethiopia in expanding method choice through the approach of task sharing. I'll be giving you a little bit of background how the government decided in terms of the task sharing. In 2003, when the government was evaluating its health sector development program, most of the maternal and child health coverage were showing change in terms of either increasing coverage or decline in mortality, both in maternal and child mortality. But the pace of change were not in line with the expected pace to reach the Millennium Development Goals by 2015. So this was the time where the government decided we cannot do business as usual, and there is a need to really see in terms of the real primary health care at the community level. And the community-based health care was introduced in 2005, where that is the most important thing for the genesis of the Ethiopian flagship health extension program. So through the Ethiopian health extension program, family planning was introduced at the village level between 2005 and 2008, almost in every village in the country, with major inclination of the short-acting reversible contraceptive methods. And long-acting reversible contraceptive methods were either none or very limited, and most of these services were given either in the urban areas or in very limited facilities. Based on these findings, in 2009, the Ministry of Health decided the introduction of the one-rod implant through the health extension program as an additional method choice in the village level, where health extension workers prior to that were providing traditional methods, pills, condom, and injectables. Whenever clients were in need of those long-acting, reversible, or permanent methods, they have to travel either long distances, or there might be some outreach services which might be given in those areas to do that one. So as part of this introduction, Pathfinder International, as one of the partner organizations, through its USAID flagship FPM-NCH program, the Integrated Family Health Program, was chosen to be part of this initiative. And initially, The initiative was led by the Ministry of Health, specifically by establishing a task force. And the purpose of the task force primarily was to really see in terms of material development, training materials, adaptation and development, identifying sites for what we call them learning sites. In Ethiopia, we usually, including our leaders, don't like piloting, the word piloting, but the whole issue of learning, based on that learning, we need to go to scale. So the learning phase was done in 32 districts, or we call them waradas, and 4 partners were chosen to do that one. Of these 4 partners, Pathfinder is one, Mary Stopes International, IPAS, and IPPF affiliate, each of us taking 8 districts to implement the learning phase. The task force was composed of partners, professional associations, and there was an independent monitoring and evaluation activity being done by FHI 360, which helped us in terms of deciding what are we in the right track or not, what are some of the things which we can see into that one. And by November 2009, there was a dissemination workshop to see what's happening, which ended up in terms of the scale up. What are some of the data which we can see? As you can see here, this is during the training. In the training, one most important thing which I want to focus is, even though it was the one-rod implant introduction training, all methods were provided during that period. So the most important thing there was, at least trainers should have a comprehensive family planning knowledge and skills. Otherwise, we cannot tell to the mother, like, we can only give you a one-rod implant, when her method choice is a different one. So you can clearly see what's happening there. Again, even removal services were given during the training period or during other approaches of backup support or the routine services. Another important area, which we published this in the International Journal of Gynecology and Obstetrics, is almost 25% of the users of the one-rod implant were below the age of 25 years. And you can see parity. We compared this with the DHS 2011 data, and you can see most of them were with parity 4 or low, compared to the DHS data where you find almost 48% were parity 5 or above. And an important thing is 23% of these clients were very new to family planning. Most of the time we say, like, it's more of like a shift from one method to the other. But what we found out is when clients are getting the method of their choice, even though they are not using it. So this is an important thing, that it's addressing the unmet need which is there in the community. Another important finding, which is also published data, is the change in terms of, like, before the introduction, it was only 7%. We changed it into over 20%. And you can see the decline in the short-acting methods from 93 to 79%. A national data clearly showed that a 6-fold increase between 2000 and 2019. This is recent data from the mini DHS 2019. So the CPR for Ethiopia has reached 40.5%, and 10.3% is related to for long-acting and permanent method. Another important area, looking at the CPR, young age use, specifically age 20 to 24, there is a steep increase in the use of long-acting and reversible contraceptive and permanent methods. This slide clearly tries to show the equity gap, which was observed years back. And from the slide, you can see here that there was almost an 8.5-fold equity gap between urban and rural in 2000. This has declined to 1.3 in 2019. Looking at long-acting reversible contraceptive methods, it was not there even in 2000, but comparing it with 2005, there was almost a 25-fold equity gap between urban and rural. That has declined to, you can see now, the urban-rural difference of 9.7 and 10.7 in the use of LARC. So we feel that the task sharing has addressed a lot, not only the unmet need, also in decreasing the equity gap between rural and urban, in the same way gap among different educational status and well-skilled types. Them. There were several challenges. I'll not go into each and every one of them, but just to show one of them is, like I have said, availing methods during training and other activities. It's a very important thing. But the whole issue of routine monitoring and evaluation. When we started the task sharing, the HMIs didn't have data related to method mix and also removal data. Today, with the advocacy from the Family Planning Working Group, it was possible to include all this data in the DHIS2 and HMI, so we can easily get data from the routine health information system. What are some of the lessons learned? We know that this was done because of the great government leadership, specifically in coordinating partners to come together and doing these activities. Again, another important lesson is the learning phase. I will only give you one simple example. The initial training for the health extension workers were 5 days. But what we found out was the 2 days theoretical and training on our models was not enough. So in the expansion phase, that 5 days was changed into 6 days, 3 days theoretical and practical in the training sites, and the 3 days clinical practices. Again, another important thing is the involvement of stakeholders, specifically professional associations. In most of the countries where Pathfinder works or most of you work, I hear that professional associations have a great resistance in terms of task sharing. In Ethiopia, one important thing which we did was professional association, including Obstetric and Gynecology Society, Midwife Association, and others, were involved from the design of the project. They were part of developing the training materials. So it's not about like by the end of the day after we introduce our program, we didn't call them like, this is the program, can you see into it or assess something. They were part of the initial program, and that helped us a lot in terms of improving into that one. Again, the inbuilt M&D system and the great supply chain is very important. These are all published materials where you can get details into that one. Thank you very much.
Thanks very much, Mengistu. That partnership and joint learning agenda, the key capturing of all of this in terms of DHIS2 and the outputs around equity and younger women are particularly striking in your presentation. So thank you very much. We're going to come back to you in a minute. Mary Jane, over to you. Great to hear now from you, Mary Jane, I think on the global perspective. We've had many key agreements with manufacturers in place during the FP 2020 era, if you'll let me call it that, and great to have some insights on how you've been working with others to support the introduction of new methods in particular countries. Thanks.
Great. Thank you, Martin. And I want to thank Elaine and Trish for the invitation to this meeting. You know, I've been looking forward to this for a really long time. I have some ulterior motives, which I'm hoping will get addressed later this afternoon when we talk about this group moving forward. But as Martin said, yeah, I wanted to, and I don't have slides, which is a refreshing change, I think, for someone from the Gates Foundation. So there you go. But I wanted to spend a little bit of time. I mean, you heard some of the great country experience of what's happened with implementing partners, supporting governments, and expanding method choice at the country level. And to take more of a bird's eye view and talk with you a little bit more about what global structures are needed to help support method choice more broadly and help countries get to their vision and goals. I wanted to start off by saying, and some of you have heard me say this before, that even though we had a program called the Implant Access Program, and we now have a program that we're working on that is the Access Collaborative, though many people call it the DMPASC program, the Gates Foundation is not about pushing single products. So to address, I think Aparna, you raised the issue of when you're introducing a product, not making it single product focused, but looking at the broad basket. So our hypothesis is that by introducing new products into a method mix, you will see greater uptake across the basket. And I think, we have the John Stover paper from 2013 that attests to that. There's program data under the Implant Access Program that also attested to greater uptake of other methods, not just implants, in countries where support was being provided, and really looking at the opportunity around a new product as a way to catalyze efforts around improved counseling, working on supply chain, working on updating HMIS and using data for decision making. So using that as kind of the hook for a broader quality effort. So I wanted to say a little bit about some of the structures that we've been involved in over the past 5 years or so that have been related to new product or underutilized product introduction. And as Martin said, in this FP 2020 era, we've had quite a bit of movement in terms of product introduction. Around the increased uptake of implants that was related to initiated by the volume guarantee, but really was about the work that was done on the ground by partners and that the donors supported to help countries expand their method mix. And then now, as we're seeing with the DMPASC work, again, looking at those structures. So some of you I know some of you in this room are very familiar with this, Layla and Jen and Caitlin, of the structures that we're looking at and that we've been using under implants and have modified somewhat for the DMPASC work. So with the implant work, because there was a volume guarantee, and this was although not all donors were signed up for direct financial efforts related to that, there was a lot of indirect work that was done, obviously, with the rollout of the program on the ground. So we had set up a donor collaborative group, which represented, we had USAID, UNFPA, DFID, SIF, the Gates Foundation, Swedish SIDA, Norway, I think I covered all of them, that would meet on a regular basis to talk about what was happening with implants and what was happening with the volumes and what was happening on the ground. And realized very quickly as we were having those discussions at a donor level that there needed to be a lot more attention paid to actually the on-the-ground realities, like what was happening with training. Were trainings too long? Were they too short? Were we seeing concerns about, implant-specific trainings? Should those be expanded to LARC trainings? When the whole NXT transition came about, that was another huge lift. And then, of course, implant removals is another key part of this. So having an operations group, which was then set up under the donor group that was looking at all of these issues that represented the donors and key implementing partners, I think was really critical. And we have found that to be really valuable, especially as we move through the NXT transition. Lots of phone calls, I remember, trying to find resources for countries to get through that. And again, I think the hope was, although the implant access program technically ended with the volume guarantees ending at the end of 2018, this operations group that was formed under the access program, which has the removals task force as a work stream under that, has actually continued. And we've been having discussions internally and of course with all the donor partners that were part of that collaborative about what's the long-term view for that group. I mean, at some point, this group should graduate into a more mainstreamed method, which is why I'm really excited about the conversation this afternoon. Similarly, DMPASC, we've had something, a very similar structure with a donor group and an operations group that is, and especially now, is super busy as countries are in their introduction stage on looking at issues around training, around supply chain, and all of that, and having that dedicated focus at a global level to try and develop resources that can be used at a country level has been very valuable. So as we've been discussing internally at the Gates Foundation, as new methods come on, how do we get smarter and more cost-effective and more cost-efficient with introduction? And how do we not tire countries out with this revolving kind of door? I think these last few years have been a bit of an anomaly in that we've had a lot of change going on. We've had, the one-rod implant coming in and then switching to a different device. We have DMPSC coming in. These are the same providers that are providing these same methods. What does this mean in terms of training, and how do we make that more cost-effective and not, again, have like new product fatigue among countries? So it's something that we've been thinking about internally, especially as we're moving towards the post-2020 world, and really one of our great interests at the foundation is around contraceptive technology and what more can be done in that space, particularly with regard to side effects. So knowing that we're going to continue to have investment in that space, and knowing that USAID is continuing to invest in that space and others as well, we're going to have this pipeline of new products coming down the line. So thinking about how do we do this more effectively, and I don't have answers to that. It's just something that we are thinking about right now, and would love if there are thoughts that people have here that they would like to share on that. I think it was an important point that was raised about what can we learn from other systems. Having a new product coming into a system in the HIV space, it seems to get out there a lot more quickly. I think we have different challenges in that we're not really looking at replacement products, we're looking at additive products, so you have to always look at the informed choice and the broader basket that's there, and that presents some challenges. And then finally, even taking it up a higher level beyond just, a new product comes on, you have structures that are supporting that product to get into countries. What is a graduation for those structures? What about even market management more broadly? And this is something that I know is a really active discussion right now among the donors. John Skibiak isn't here today, but RHSC has been doing a lot of work in this space and looking at issues like, is there sufficient supply in the market for quality assured products? We know right now there's a big issue with the one-rod implant, and there not being sufficient supply. That constrains demand, and that artificially, affects your MCPR if you're looking at a scenario where you don't have sufficient supply in the market. Who's looking at that? Who is looking at the relationship with manufacturers, which RHSC does to a certain extent, but thinking about how we can have a market management function that is a bit more formal for our sector, which we haven't really had before, that's looking across the methods, that's looking at manufacturers and sufficient supply and how you could get other manufacturers to quality assurance, and then also looking at as new products come on, what support that broader market management role could play on a market introduction strategy in those countries. So just some thoughts. Again, no answers right now, but these are some of the things that we're grappling with right now at the foundation, especially as we look at post-2020.
Thanks very much indeed, Mary Jane. And actually, we're gonna get a bit cozier now, but partly because we want to get closer to you, and partly because the camera, I think, needs to capture us. So if you could move in towards each other, Mengistu Kathari, that would be great. So I said we would be collecting those questions that you have. I hope somebody's got them. I see them in I think Leah may help with gathering those. But just as we do that, a quick follow-up question for each of our panelists, if that's okay. Starting with you first, Aparna. So excellent to see the data from India, from Odisha and Haryana. Would be excellent just to hear your programmatic recommendations. Wow, that's a fistful of questions. Programmatic recommendations, particularly in the light of what maybe a question in here, the specific context of India and how those programmatic recommendations may be able to resonate with other countries. Thanks.
Sure. Thanks, Martin, for that question. So I think from the context of India and sort of what we're seeing in terms of quality of care and the introduction of new methods, anytime a method is introduced, and the co-panelists also touched upon this, it's an opportunity to reintroduce quality of care as something that is routinely offered regardless of which method is being introduced. In addition to that, I think there's opportunities in India to use ASHAs and private and providers and the entire system in interesting ways. So for example, where ASHAs could be the follow-up mechanism to recently adopters of family planning to ask about side effects, to ask about how they're feeling. Are they able to manage them? And if not, encourage method switching, link them back to the facility. So perhaps the ASHAs could also, in addition to being that provider who initiates contraceptive use with the client, could also play a different role in terms of method switching and follow-up. So I think I'll stop there.
Yeah, great. Okay, thanks very much, Aparna. And I said this would be quick fire. So, Gathari, over to you. And I just wanted to link back to a comment that came out of Michelle Weinberger's presentation this morning around continuity of financing, particular for new methods. And it'd be great to get your reflections on the Kenyan increase in LARCs, particularly implants, and the continuity of financing over the longer term, and perhaps just commenting on the National Health Insurance Fund in relation to family planning service delivery. So an easy question for you.
Thank you, Martin. Yeah, easy, but obviously, of course, you know, some of the difficulties in terms of just securing funding or financing for the health sector has not been easy in many of these countries. And I think in Kenya, one of the things has just that advocacy element. And in fact, when you sit down with the leadership of the government, the question that keeps coming up is, how do we adopt a method that is reasonably expensive when you don't even have finances for the regular, less expensive commodities? And if you are skewing the method mix unnaturally, then how do we guarantee security? How do you guarantee sustainability in a self-reliant manner? And those are not easy conversations, but of course, being able to demonstrate to them the value of you are adding to the availability, or just women having a wider choice to get from. But obviously, this requires concerted efforts across the board, so that then we're able to impress upon the governments themselves to be able to invest in the care and welfare of their people. I think that has been one of the things that we keep seeing. And when we sit down with them, there has been a lot of concerted effort. But even as we speak now, and this has been across Kenya, in Zambia the same, you still have huge deficits in just commodities, financing for commodities. And we also appreciate the fact that, of course, development partners have been stepping in to cover that gap. But I think we are also seeing them beginning to demand of the governments to put in something, so that then they can say, as a government, there's the amount of money we have for this, but we are not able to reach to cover the entire envelope. And basically, being able to demand a little bit of more accountability across the board, I think, is something that we need. We cannot stop doing, all of us, especially citizens of the countries that so much require these services.
Thanks very much, Gathari. So on to you, Mengistu. So quick question for you. So beyond increasing access to LARCs in Ethiopia, what do you think are the drivers to further improve method choice, particularly for those who are in rural areas and those important younger groups of clients that you set out in your presentation?
Thank you so much. The first important thing which we probably learned is the government commitment and the development partners coordination in terms of really looking at sharing responsibilities and also responding to the needs in the ground is a very important thing. The other important area is the existence of the community platform was used in terms of expanding the program throughout the nation. And that helped a lot for the national scale-up. So the task sharing was a very important driver in terms of increasing the coverage, specifically in the areas of LARCs. When it comes to, rural and youth, as I've already said, like the community-based services was an important factor for reaching rural community. And in most cases, geographical access is a huge issue. Traveling, usually we think that like if commodities or services are available somewhere, women can use it. But the truth is, there is an additional opportunity cost for them to pay for transport, to leave their household chores. All these things, as program, were not costing them. And so the more services nearer to them, that's making a difference. For the youth, having user-friendly services or user-friendly environment at different levels, including the youth network through peer educators and others, is making a great difference in bringing about the change in terms of the method choice and then the coverage.
Thanks, Mengistu, very much indeed. So, Mary Jane, on to you. Great to hear about your the idea of a market management entity. I wanted to have your reflections on what you've learned as a foundation from the Implant Access Program, from the Access Collaborative, that you're going to be taking into that thinking around investment in new contraceptive technologies and this market management potential function.
Thanks, Martin. I think some of the key lessons that we've learned and the opportunities that this access, the Implant Access Program and DMPASC presented was for a closer coordination among donors. Even though it was originally around a single product, often it got expanded, and I think to have insight into each other's planned investments or ongoing investments and talk about how we might want to shape our investment thinking going forward was really valuable. I think the other really key part was this relationship with manufacturers, which, I think they appreciated it very much. I still hear quite a bit from Bayer and Merck about their partnership in that effort and how much they valued having insight into what was happening on the ground and into women's access to the product. Also seeing the same from Pfizer. I think that's been, so from the manufacturer perspective, I think having that closer connection to where their products are winding up and doing that through this kind of community has been really valuable. And for the donors, having access to those manufacturers to work with them on problem solving and planning around, again, I'm going to come back to the NXT transition because that's a really painful part of my time of my life. Like working with the manufacturers through that process and having kind of that really close collaboration was really valuable. So I would love to see both of those things going forward, is this continued close coordination among donors, especially as we're talking about new product introduction, and then having that open relationship with manufacturers about needed products as well as where they wind up and what that means for women.
Thanks very much indeed, Mary Jane. Sorry to take you back to a traumatic time. So can you pass the microphone to Gathari, because you've got the first question. And thank you very much. I think there are probably 10 or 12, and we have fully 30 minutes, so I hope that we can get through them, although more seem to be coming as the time goes on. So Gathari, with the price guarantee for implants, how do we know if the increase in use is due to the program provider push of the method, or actually what women really want?
Thank you. I think that's a great question. And if we are not careful, then we can push down a method, that is probably not what the women would want to use. But I think one of the things we've seen is that the other methods have still remained, presently available across the board. And what we've been able to see is also having conversations even with the women themselves. We have a community health strategy platform that then allows us women to engage with community health volunteers who then interact with the formal health sector, and they are able to then pass on their concerns and their issues so that then they can be addressed. I think also, progressively what you've seen is also younger women, beginning to use contraception because of, basically providing a platform where you're able to engage and converse. And one of the things we've seen is, of course, with young people, they want to be heard. They want their voice to be heard even before you can be able to say this is what the methods are to be available for you. But I think the empowerment of women, of course, would again take center stage, so that it doesn't matter what the provider is saying. First of all, is then being able to consider what is it as a user, what would be the most appropriate method for me, and then being able to have that conversation with the provider and being able to genuinely, ultimately be able to agree on what is acceptable. Of course, within the purview of medical eligibility criteria, I think that's also pretty important. I think the other thing we've seen too is basically we are seeing in Kenya, we've seen a lot of citizenry getting a little more aware of their rights, being able to demand services a little more. I think if you look at the generation of people now we have, they're actually a little more vocal. They are vocal than they used to be. So we are seeing a lot of that being able to see. And in fact, even at the facility level, you've had incidents of a community actually deciding we do not want this particular provider to be able to giving us service. And I think basically that's what we want, so that then we can be able to improve the quality of the service that you're providing.
Thanks very much. Yeah, add on to that, please, Mary Jane.
Thanks, Kitara. I did want to add on, at least from some of the work that the foundation had supported around service delivery when the volume guarantees were signed. This was top of mind for us, and in fact, some of the program data. I don't know, is there anyone from Engender Health here? Because they did some really great work on client exit interviews. When we saw the data coming in from DRC that out of their mobile outreach, 80% of the methods being selected were implants. We're like, whoa. Can this possibly be true? And they did incorporate client exit interviews, which it's hard, you can't make those routine, but at least as a one-off, in the 3 countries where they were supporting the implant service delivery work. And we did see that women said they were getting the method that they wanted. They had been counseled about other methods. They were getting their choice. And I think Jane knows that it was just such a latent demand in DRC, especially, that it was surprising, but it shouldn't have been surprising. So I think as we look at, and I'm pretty sure PMA in the MII, this is a way to kind of capture some of that data if women are actually getting what they're doing. But I do think we have to pay attention, especially with new product introduction, that partners who are actually working on service delivery do have some level of quality assurance through client exit interviews or some other effort to particularly address that point around coercion.
Great, thank you. And that's a very good segue. Can you pass the microphone to Aparna? Because the next question is about the MII+. And by the way, when Aparna was presenting, Scott nodded in terms of the MII plus question being included. Yeah, on switching, absolutely. So the question is about switching, but the question is provocative, nicely provocative. Isn't switching already covered in the MII as it already exists, without the need to add the additional MII plus question on switching, in terms of counselling around other methods and how to manage the side effects? Isn't it already included? Why the need to add to the MII, Aparna?
Yeah, it's a good question, and the question is that when we looked at the data that we collected in India, we did find that women who were specifically told about the opportunity to switch were more likely to continue to use contraception 3 months later compared to women who did not receive that information. So I think that when we say that something is inherent in a question, that to me doesn't resonate very well. Either it's there or it's not, and if it's not there, and it's not explicitly there, then it doesn't necessarily mean it's being interpreted and understood by all providers equally, and subsequently clients who are being asked the question. So I think it's a really important piece that needs to be included within the MII, just to ensure that women are in fact getting the information that they need to have a full and complete choice around contraceptive use.
Thanks very much, Aparna. So Mengistu, a suite of questions for you here, if that's okay. So observations from colleagues in the room and on the phone about the decrease in urban areas between 2016 and 2019. Most of the gap in the LARC decreased because it went down in the urban settings with only a small increase in the rural. What happened between 16 and 19 in urban areas? I'm going to ask you a second question as well, which is that when you talk about community health extension workers at the village level, do you mean based within a facility or in terms of their interaction with households or indeed other locations within the community? So two questions for you there, Mengistu.
Okay. First of all, the 2016, the 2019 is a mini DHS data. Probably the past 2 years in the country, there were national turmoils, security issues, and others, where that might affect a little bit in terms of the coverage, both in the urban or rural areas. Probably with the next DHS, we may see those really change into that one. When it comes to the community health extension workers, basically, in Ethiopia, these community health extension workers are not volunteers. These are government salaried workers stationed at the village level, and either the government or local community will construct the health post. So basically, they might, all of them are women. 2 of them are stationed in a village with an average of 500 to 100 household, and one of them can be out in the field to do household visits, but they have also community volunteers who are helping them. In the past, when we talk about community volunteers, they were very much extended, where 1 or 2 volunteers may be working throughout the whole village. In the current system, a community volunteer cannot go beyond 5 households, 5 neighboring households. So there are a lot of volunteers who are in the community who are helping the community health extension workers. So there is a facility in the village, but additionally, they also go out to do some of the community level activities.
Right, as the hub, in essence. Excellent. Thank you very much. So we now come into the realm of questions that are posed to all of you. So the microphone is going to be past the microphone. Whoever's got the microphone now has to answer first. So and this is a great one. So maybe you want to hang on to it. How are decisions made to introduce a new method? What drives introduction? So this is a very interesting question. Be very, very good to start at the country level. So how do those decisions actually get made? Mengistu, you're holding the microphone. When you think about recent experience in Ethiopia, does that conversation get started at the political level, at the technical level? Where does it get going?
For us in Ethiopia, the major role is within the National Family Planning Technical Working Group. And the National Family Planning Technical Working Group is composed of both government and non-governmental organizations, including professional associations, where we can use existing evidence in terms of what is lacking in terms of method mix. For some of the rural women, for example, when LARC was introduced at the rural level, they were really telling us they thought this was only for the well-to-do, because they can only get it either in few private clinics or clinics in the urban areas. This was not for them. But when this was introduced, that really helped, convinced them they can easily get it in their own village hubs or in their own village health facilities. So the Family Planning Technical Working Group plays a major role, but for the government leadership makes it a big difference in terms of that one. Sometimes I think non-governmental organization can introduce in a certain small scale, but if government is not leading that one for scaling it up, it's a problem.
Okay, wonderful. So is the Kenya experience roughly the same, or how would you
Yeah, it
compare
is
or
similar.
contrast?
It is similar, Martin. And the beauty of just having this conversation beginning at the technical level is just the fact that, people have synthesized evidence, whatever it is, the benefits, both, contraceptive and even non-health benefits. But beyond that is just looking at the fact that while these technical working groups, consist not just the government, but also development and implementing partners, provides a very good medium upon which to basically have open conversations and looking at all the elements of the health system's building blocks. But beyond that, what I've seen increasingly in Kenya, like with the implants, was that the manufacturers also now began having these conversations with the rest of the team, the technical teams. And I think, of course, we as the part of the government, and of course government taking leadership, but I think when you begin opening this conversation to manufacturers, I think we also need to be a little cautious so that they do not push their agenda without necessarily looking at the bigger picture. I think the other thing is, of course, we keep on talking a lot about this. Of course, when you're bringing all, whatever new method, especially for contraception, it has to be, when women are getting, it has to be within the, again, the principle of informed choice and voluntarism. So we can never lose sight of that. And I think for us too is that once the government buys in, the rest of it becomes easier to go down through the system, the whatever supply chain management and all that. But also at the user level, I think I still want to be able to remind us that the user becomes also a very important member of this conversation, because ultimately they are the ones who have to take in and live with the side effects, if there are any, but also being able to know what do you do when these side effects come? Are there things that you can be able to manipulate or live with them, all those, because then we'll begin reducing or minimizing the need for them to take out the method and wanting to get rid of it soon after that.
Thanks, Kathari. Any reflections on introducing new technologies or market shaping at the global level, Aparna, Mary Jane, in relation to this question? How decisions are made about introducing new methods and what drives, we remember your very well-made point earlier on, Mary Jane, what drives introduction? Any reflections?
I guess I'll answer that one,
Yeah.
Martin.
All right.
I was just sitting here thinking about this because, so I'm just thinking about implants, and implants were kind of a different situation, that they weren't necessarily a new product, but they were underutilized because of price and all of those things. So I think where the decision came, or why the decision was made to put some effort behind implants, was what we were hearing from the field, that this was a product that women wanted, that governments wanted, that it was cost prohibitive. Governments were choosing other less expensive products when they were doing their supply planning because they didn't have the sufficient funding for this. So I think it's really important to, in that particular instance, it was about responding to what we knew about demand from the field. And I think going forward, it's also about being responsive to what women want, touching back on some of the things that Rebecca mentioned earlier. Having a more solid understanding of concerns about side effects and duration of action and all of that, and really taking that into account before we even get into the new product development piece. And I think the donors are getting better at that. I think we're trying to get better at that. And I think one other important point is, as we're looking at new product introduction, that we really consider the price and the sustainability, and which is why, along with the implant, the volume guarantees with the Western manufacturers, there was an effort also to develop a generic manufacturer, Dawa, who's now offering the product. Same for DMPASC. There's an ongoing effort to work on a generic that we should have in 3 to 4 years. But hopefully sooner.
Changed in the space of 5 seconds.
I'm trying to remember my latest talking point on this. I think probably within 3 years, but obviously it's important not to have, and this is a concern we've been hearing from countries, especially around DMPASC, is about a reliance on a single manufacturer. If a product gets introduced, what happens if that manufacturer is not able to meet supply, but what also happens if that manufacturer increases the price? So trying to create more competition in the market.
Thanks very much. And whoever wrote that card, I got to 2 of your 4 questions. I might get to the other 2 if we have time, but I need to move on. So, and this is a question for all of you, whoever would like to answer. In the last panel, we saw women express that irregular menstruation and no period is highly undesirable in their choice of a contraceptive method. How do we reconcile this with the very large increases that we've seen in implant use, which is a method where women experience either no period or irregular bleeding? How are we reconciling what we understand from the previous presentation of what women want with regards to the large increase in implants? Gatari, sure. Thank you.
So thank you for that question. It's a great one. I think one of the things you've seen, and of course we do recognize a huge proportion of women using, the implant, getting amenorrheic, is the fact that, of course, I think client education, making sure they do understand how the method works, and that not having menses does not mean that they are going to get infertile. But also, I think the other element has been that just the fact that there's the option of switching or removing that method at whatever point in time, and the woman actually recognize and appreciating that for any reason, if you go home in the evening and you don't want to use it, a service for removal is actually available. And I think we need to move towards that, because a lot of these methods are difficult for self-care, unlike DMP sub-Q. But I think we need to also begin, and that's why we still insist on being able then to make sure that the quality of the services we're providing are so good that, a woman actually does trust us. The client actually trusts the provider so well that really she knows that, the provider has the best of her interest at heart. That for any reason, if she goes and finds the method is unacceptable, she can actually come and have it, removed or switched to another one. In Kenya, what we've also introduced, and introducing in our tools, is to also begin identifying, to understand why women are coming for discontinuation. Is before such a method is discontinued, we also want to explore a little bit, what is it, the reasons why they want it removed, and do they consider using another one. And just want to begin building data, which then we can be able to utilize to get a better understanding of the profile of what women actually do want to use.
Thanks, Gatari. Aparna.
So I don't think I have a direct response to the question as it relates to implant use, but I did want to mention that we had done some qualitative work in Bangladesh, and we found that irregular menstruation not only impacts the use of the method, but it also impacts women's lives, like their daily lives. And when you're talking about, we did this in Bangladesh, so it's a highly religious country, a Muslim country, so when you're menstruating, there's certain things you can and cannot do. And so I think we have to start thinking about this idea of menstruation that goes beyond just like the physical effects on a woman's body and how it relates to her choices around use and non-use, but also how does that ultimately then impact what she can and cannot do in her relationship and intimacy with her partner, in terms of her, her religious communities, in terms of her ability to do things around her house. So I think there's opportunities for us to start thinking about it more broadly, I would say, and more holistically with the woman at the center, but not just the physical manifestations of the method.
Right. Thanks very much. Mengistu.
On top of what was said, one important thing is, which relates to the quality of care. Are we giving a proper counseling or not is an important thing to be asked. Sometimes they are not told about it, and they came with that complaint. So that's the whole issue. This is not only with contraceptives, with other medications also. So the whole issue is, are we really counseling properly is the very important part of it. So the quality of care in relation to counseling is an important component of it in solving that.
Thanks very much, Mengistu. Shall I move on? I've got several more questions here, and we're counting down. 10 minutes to go. Here we go. So, Gatari, you mentioned that the rate of increase in removals was much lower for IUCD compared to that for implants. Can you elaborate on this a little more and discuss why you think this may be the case in the Kenyan context?
Thank you. So, yeah, and again, of course, like I mentioned earlier, the uptake of IUD has not really shown a very dramatic rise. But subsequently, what we've also seen in terms of removal is really not as similar. And it could be, again, related to just what information women do have in terms of the side effects that they are likely to encounter when they're using the method. And also the fact that, it could be really be the fact that, in our earlier question, where perhaps did we genuinely push this method or not? Or is it that the fact that, we are skewing the method availability unnaturally? And so we'll find a level whereby maybe just because these are the methods that are available and these are the methods that, everyone is talking about, then a bit more women are taking them rather than taking what they would have naturally picked on. And if they do that, then they get home and find that really this is not what was most appropriate for me, then we are going to get into this mix. And I think, just like Mengistu says, until we go back to improve the quality of our counseling, the quality of our services, we are going to get ourselves in a fix. And the danger too is that we also know that, like we talked earlier in the morning, women's social network, the way they communicate and talk a lot, so-and-so is using this. And if she found that somebody she knows did not find it don't fare too well with that method, then you are likely to get into difficulties, especially because that is also a very powerful tool in how women make decisions on what to use. So in terms of basically then making sure that the supply side of it is so up to speed in terms of being able to provide the best within whatever whatever is available. Of course, we do also recognize and appreciate that sometimes circumstances are such, certain methods run out and the only available is this method, And then under such circumstances, what does as a provider do when a woman is in front of her and she would really wish that woman could go home with a method, because the consequences of having an intended pregnancy are so dire that, the question is, that conversation is also difficult. And I think the bigger thing is just to make sure that we avail these methods as much as possible, make them available at the lowest level, where the woman lives, so that then they can actually be able to genuinely make choices of the methods that they're actually going to get. I mean, there are very many times when a woman would prefer a certain method, but it's not available. Then what happens subsequently? And I would not be surprised such a woman then comes later and would prefer to have it removed. So those are really part of the advocacy we would really wish, and I think we do wish that these methods, and we are happy to hear, perhaps less expensive generic commodities being available. I think it would be very helpful for us in these countries to actually have methods that are really affordable and within the reach of the majority of our women.
Thanks very much, Gathari. We're on the penultimate question. It's for you, Mengistu. So our questioner says you referenced the reduction in inequity in the use of family planning methods. We remember those graphs, I think, related to rural and urban and educational level. Our question is, how did you decide that there were inequities between these groups in the first place? Which I think I understand, but I thought your graph showed relatively clearly that there were big gaps a decade or two ago that had been narrowed. But can you just clarify a bit more?
First of all, I mean, looking at 2000 or early 2000, most of the services were available either in urban, peri-urban areas. So with the health extension program going to every village, that first of all is becoming like reaching the underserved, so they can easily get those services from their own in the same village, rather than for most, like prior to 2005, they have to travel probably 30 to 40 kilometers to get an injectable. Now they are getting those services in their own village. Because of that, you can see the number of users both in the urban and rural areas are more or less similar, rather than the big gap which was there in early 2000. So that's the most important part of it in decreasing the equity gap between urban and rural in terms of use. Again, with the service being available, whether someone is illiterate or educated, they can easily get those services. That's also creating an opportunity to minimize the gap in services.
Thanks very much, Mengistu. Last question for you, Githari, which is around the LNG IUS introduction that you took us through. And this is a good one because it relates to unforeseen circumstances. So what was the impact of industrial unrest and the related sort of human resources for health shortage on the introduction of a new method, in this case LNG IUS in Kenya?
Thank you. Yeah, in Kenya we're also going through some period in terms of our governance with the introduction of devolution, and that also means that subnational governments, or known as county governments, are sort of semi-autonomous units, and we've been seeing a lot of industrial unrest in some of them, delays in paying salaries and the like, and of course that has impacted. But one of the things that's surprised, I don't know, especially in the setting of the study, was that even when the public health healthcare workers were on strike, the mentors or the teams that were already working on LNG IUS continue to be highly motivated to actually continue providing the service. We found it really interesting. In fact, in one of the counties, they would go to the hospitals or to the facilities without the uniform, just to make sure that they are not, harmed by their colleagues. And it is a very interesting sort of setting whereby you do identify really a few genuine providers who are very interested in sort of providing some of these services. I do recall, in fact, during the time of MCSP, just identifying one of the facilities, somebody who even comes to open the facility over the weekend. She doesn't have to do that. And so there are some good people who we could tap into and try to utilize. But of course, issues of industrial action will, until we resolve the issue that we have in terms of governance, in terms of employment, we are definitely going to expect that they are going to interrupt services holistically. But in some of the settings, in some of the counties that you're working in, what we've also seen is that a very good and open relationship with the private sector, especially the small sort of private providers, so that if there is, in the event that there's the public sector is closed, then women can still access services from this. And these two, especially the faith-based, the mission hospitals, have also played a good collaboration. Of course, this has to be mission hospitals that believe in modern contraception, and we are also really cognizant and very respectful of whatever services that they're able to provide. So just having a genuine and very open conversation in a setting, in a community, I think would be very helpful in overcoming these multiple challenges that we are likely to encounter even going in future, even with additional methods.
Thanks very much, Githari. And as we move into the last minute of this session, I'd just like to let everyone know that by the end of this week, the next iteration of the vision framework for the next family planning movement through to 2030 will be published on the FP 2020 website, familyplanning2020.org/beyond 2020. And your views are absolutely critical. You'll see there within the vision statement, within the guiding principles that underpin all decisions around the next FP movement, and you'll see in terms of the focus areas a very clear emphasis on full method choice. We do want your views, though. This is not the final word on this vision framework. This is a consultative process. So we will, I hope, let you all know about it. I'll make sure I have all of your email addresses. But the panelists, all of you on the phones and in the room, we do really want your views on the overarching vision framework and the importance of method choice within this. So please do stand by to receive that tomorrow and get back to us very quickly. So having made that plug for the next 10 years, I'd like to thank my 4 panelists for all of their incredibly important and significant work over the last very many years, and for your excellent presentations. And also sincere thanks to Anne and to Leah and the rest of the team that helped to put this panel together. So thank you very much indeed. And I hand to you now, I think, for a logistical announcement.
Wonderful. Thank you so much, everyone. And for those that, if you are still online, we will have online viewing for the debate this afternoon. So you can still join us. But it's everyone's favorite time. It's lunchtime. So please help yourselves. We have a nice hot lunch. I know it's been a little chilly in the room. That'll probably feel good. Lunch is back there. Remember, restrooms on either side. They're all gendered, which means boys, girls, any gender share. And if you have any questions, let us know. We have 45 minutes, so we'll be back promptly at 1:30.